Okay, so yesterday we have discussed about the inflammatory bowel diseases. Okay, we have discussed their cause, the location, their types, right? What you will see on the endoscopy or the cross morphology, what you will see in the biopsy of the patient, the clinical features, the complications, right? The the intestinal complications and the extra-intestinal complications we have discussed, and finally treatment. Okay, we have gone through everything, right? And today we will be starting with the irritable bowel syndrome. Okay, so irritable bowel syndromes, you need to remember two, three things about it. First thing, the patient will have a pain, recurrent pain, okay, which is related to a defecation. Whenever the patient is trying to defecate, he or she will have the pain, okay, and as soon as he done with the defecation, the pain will be over, right? So it would be it would present as an abdominal pain, okay, that happens while defecation. Second thing is a change in the stool frequency. Okay, the patient will start, will start going for the stools for like 3 to 4 times a day sometimes, right? Or sometimes they can even get the constipation. Okay, so they won't defecate for even 3 or 4 days, right? So either the diarrhea could be there, okay, or the constipation could be there, right? And third thing is the change in the consistency of the stool. Okay, you will also have a change in the consistency. Either the stools become too much hard or they become too much watery type, right, or liquid. Okay, so the pain will be there, okay, with the defecation. Stool frequency will be changed, either increase or decreased, right? And the consistency of the stools will be changed, either increase or either decrease. Whenever you encounter these three things, you will immediately know that the patient is having a irritable bowel syndrome. Okay, for any cause of the diarrhea, okay, which you can't explain by any other disease, right? You have run all the tests, okay, all the tests came out to be absolutely negative, absolutely normal, right? Then you will diagnose the patient with the irritable bowel syndrome only in the last. Generally it is seen in the middle-aged women. Very important. Okay, no structural abnormalities are there, everything is fine in your body. Okay, the lab values are normal, the endoscopy is normal, the microscopy is normal, everything is normal. Just the patient is having a pain, a very prolonged history of pain for like years. Okay, they will tell you that they are having this pain, and the change in the stool frequency for like 3 or 4 years, right? So whenever you get the history of diarrhea for like 3 to 4 years or 6 months, right, then you will know that this could be a case of irritable bowel syndrome, because you cannot explain this diarrhea with any other disease, right? Very important. So symptoms will be chronic always, okay, or maybe sometimes there could be the diarrhea predominant, there could be the constipation predominant, or sometimes they could also be mixed. Okay, the pathophysiology is always multifaceted, okay, factored, and the first line treatment is the lifestyle modification and the dietary changes. Nothing to understand more about this disease. Okay, just know three things. Okay, the pain while defecation. Okay, the change in the frequency of the stool and change in the consistency. It will always be a young patient having a very prolonged history of diarrhea. Okay, without any fever, of course, right? And this kind of diarrhea you cannot explain with any other disease, right? Because the patient is having a very prolonged history, like 6 months or sometimes even the years of history of diarrhea, right? And the treatment would be only the lifestyle modification and the dietary changes, right? Nothing more. Any doubt on this irritable bowel syndrome?
Oh, thank you.
Then comes the appendicitis. Okay, appendicitis is basically the inflammation of the appendix. Okay, and and there must be a cause of the inflammation, right? The cause and the most common cause is basically the obstruction by any fecalith. Okay, obstruction by any fecalith. Okay, whenever you have the whenever you have the this obstruction, right? So before the obstruction, the pressure will be increased, the interluminal pressure will be increased. As a result, the blood supply to that structure will be compromised. Okay, ischemia happen, hypoxia happen, right? And that can lead to the inflammation, right? And the bacteria which are present in the appendix before the obstruction, okay, the proliferation of these bacteria will happen, right? And they further promote the inflammation. Okay, so because of this obstruction mainly by the fecalith, okay, you can have the inflammation of the appendix. Why? Because of the compromisation in the blood supply. Okay, ischemia, hypoxia will happen, that can lead to inflammation. Overgrowth of the bacteria in that region will happen, and they can further promote the inflammation and necrosis of the appendix, right? That's how you get the appendicitis. Okay, so in the adults, the most common is the obstruction by the fecalith. In children, it is by the lymphoid hyperplasia. Okay, and this lymphoid hyperplasia can happen after any infection in the GI tract, right? Any case of the gastroenteritis, right, in which you are having this lymphoid hyperplasia, the patient can get the appendicitis, right? So the proximal to the obstruction of the appendix, the luminal pressure will be increased, right? And whenever the luminal pressure is increased, okay, what's gonna happen? It will irritate the visceral afferent nerve. See, the first one, the first nerves to be affected are the visceral afferent nerves, okay, which supplies by the root T8 to T10, right? And that's why initially the pain of the appendicitis will happen to the umbilicus, will be the periumbilical. Why? Because of these nerve fibers, the T8 to T10, right? We have discussed whenever you have any pathology that is affecting the midgut structure, okay, the pain is always going to be the paraumbilical because of this T8 to T10 levels, right? So, so in case of appendicitis, the initial pain will be in the paraumbilical region because of the afferent nerve fiber irritation, right? As the inflammation extends, or I can say that as the inflammation proceeds further, right? After the appendix, it will involve the peritoneum, right? Because of the transmural inflammation, the appendix will be ruptured, right? It will involve the peritoneum also, okay, and the patient will get the peritonitis, right? By the irritation of the peritoneum and after the peritonitis, the pain will become more localized, okay, because the somatic nerves supply to the peritoneum, right? So you will get a very localized pain, okay, which is localized into the right lower quadrant at the McBurney point, okay, which is a 1/3 distance from the right anterior superior iliac spine to the umbilicus, right? If I annotate it, this is your umbilicus, right? This is your anterior superior iliac spine, okay. So 1/3 the distance from here, okay, and 2/3 the distance from here. Oh, sorry, it's 1/3 the distance from here, okay, and 2/3 the distance from here. This is a McBurney point where you will get a very localized pain whenever the peritoneum is involved. Okay, so this is the appendicitis. You will have the inflammation in the appendix. Initially, the visceral afferent fibers will be irritated, and the pain will be in the paraumbilical region. As the inflammation progresses, it will irritate the peritoneum. It will cause the inflammation of the peritoneum, the peritonitis, and uh, as a result, the pain will become more localized. Okay, this peritoneum over the appendicitis, okay, it will become very inflamed, and that's why the pain will be happening in the right lower quadrant region, right at the McBurney point. Okay, so this is the pathophysiology for the for the appendicitis. Now symptoms, it includes a nausea, vomiting. Okay, the patient will get the fever also, right? And the patient will also get a very severe pain initially in the paraumbilical region, then and then localized to the McBurney point. Okay, the patient will also get the guarding and the rebound tenderness of the abdomen, okay, because of the peritonitis, right? Sometimes what happens is this appendicitis can also irritate the psoas muscle, okay, and hence the nerve which supplying the psoas muscle, it will become very irritated, right? And in that case, you can also have a psoas sign, okay, in which you have the extension of the thigh and the internal rotation of the thigh. sorry, the flexion. You will have the flexion and the internal rotation of the thigh because of this psoas sign, because of the irritation of the psoas muscle. You guys know that psoas muscle is involved in the flexion at the thigh, right? So whenever you have the irritation of the psoas muscle, okay, or the nerve there, okay, and it will cause the thigh flexion along with the internal rotation, right? And sometimes the obturator muscle can also be irritated, and that can lead to the internal rotation of the thigh again, right? Guarding and rebound tenderness would be there, okay? And the psoas signs and the obturator muscle involvement, the obturator nerve involvement, it would be seen in the rectocecal appendix. Whenever the appendix is more posterior, okay? So retrocecal appendix, you will see the psoas sign and the obturator sign, okay? And yeah, that would be it. So you can sometimes confuse the appendicitis with the diverticulitis, but note that that diverticulitis would be in the elderly patients only, and most commonly it is on the left side rather than the right side, right? So and secondly, you can also confuse it with the ectopic pregnancy. Okay, so you have to do the beta HCG test to rule out the pregnancy, right? And sometimes it can also be with the pseudoappendicitis pain. If you guys remember, what organism can cause a pseudoappendicitis?
Yersinia.
Yersinia. So you can have the pain similar to that of appendicitis in case of pseudoappendicitis also. You will have to do the endoscopy of the patient, and there you will see a normal appendix, and that's how you know that the patient is having a Yersinia pestis infection, not the appendicitis, right? Treatment will be the appendectomy. You have to remove the appendix, okay? And the tinea coli are used as the surgical landmarks, okay? Because all of the tinea coli, they will converge at the appendix, okay? The tinea coli, they will converge at the appendix, and that's why you can use the tinea coli as the surgical landmark, okay? If you're unable to palpate the appendix, right? So you can use the tinea coli instead. Okay, any doubt in the appendicitis?
No, thank you.
No.
Just know what the appendicitis is, then the cause of the appendicitis, the cause of the pain, why the pain is happening, right? Then other symptoms associated with it, right? And the complications. Okay, you will study under these headings. Okay.
Yes.
So now comes the diverticula of the GI tract. Okay, so what a diverticula is? Diverticula is, is the pouching from the GI tract. Okay, any kind of pouch that is formed from the GI tract, we will call it a diverticula. Okay, so a blind pouch which is protruding from the alimentary tract, okay, or I can say the GI tract, okay, that communicates with the lumen of the gut. It must communicate with the lumen of the gut, okay, and it generally happens because of increase in the pressure within the lumen, right? When the pressure is increased, then at the points where the wall is kind of very much weak, right, it will it will be it will become the outpouching will happen at that point, right? And because of the outpouching, it will known as the diverticulum. You have two type of diverticulums. One is a true diverticulum, and second is a false diverticulum. Okay, a true diverticulum will contain all the gut layers, right? Which includes, tell me the layers of the gut.
Mucosa, submucosa, muscle layer, and serosa or adventitia.
Exactly. Okay, so whenever this the diverticulum contains all the layers, then you will call it a true diverticulum, right? But whenever it contain only partial layers, for example, say the mucosa and submucosa only, okay, you will call it a false diverticulum. And most of the diverticulum in your body are the false ones, okay? And remember, the diverticulum only formed where the wall is very much weak, like in case of the false ones, okay? The site where the vasa recta perforates the muscularis externa to supply the GI tract, right? You have the vasa recta in the GIT, okay? That supplies the walls of the GIT, right? It need to pierce the muscularis externa. So as you can see, if it is piercing the muscularis externa, right? So this point will be the weakest point, okay? So at this point, the diverticulum will be formed whenever the interluminal pressure is increased, right? So the cause of the diverticulum is to increase in the interluminal pressure. Okay, most of them are the first diverticula, right? The only two diverticula you have is one is the Meckel's diverticulum, if you guys remember, right? Meckel's diverticulum is the true diverticulum. Rest most of them like the Zenker's diverticulum, right? And the other ones, they are all the false diverticulum, right? Then you have the diverticulosis, okay, in which you have multiple diverticulars. Okay, whenever you have a multiple diverticulars, okay, you will call that a diverticulosis. Okay, many false diverticula when arise from the colon. Okay, and most common location you need to remember, it is the sigmoid colon, and because the sigmoid colon is on the right side, so whenever you have an inflammation in these diverticulars, the pain will be in the right side, and that's how you can differentiate this pain with the appendicitis, because left side, not the right side, but the left side, right? So you can differentiate this pain with the appendicitis pain, because appendicitis pain is in the right side, and the pain of the diverticulosis or the diverticulitis would be in the right side. The left side. What I'm saying, left side. Okay. Most of the times, it will happen in the people which are more than 60 years of age. So whenever you encounter a case of diverticulosis or a diverticulitis, it's always going to be a case of old age patient, right? And that's how you can differentiate this diarrhea and pain with the inflammatory bowel diseases, right? Because these diseases will only happen in the young population, right? While the diverticulitis, it will happen in the old people, right? So the cause includes the increase in the intraluminal pressure, okay? And that happens whenever the patient is having a history of constipation, right? Or he might be taking a diet which is low in fibers, okay, and high in the red meat or the total fat. Whenever the fat content or the red meat content is very much high and the fiber content is low, or the patient is having a very chronic history of the constipation, right? In that case, you will have an increased intraluminal pressure, okay? And the site where the wall is very much weak, which is the side where the vasa recta perforate the musculus externa, okay, the outpouching will occur, right? And it will form some diverticulosis, right? Most of the times they're asymptomatic, okay? When they're absolutely normal, the patient will be asymptomatic, okay? Sometimes the complications like bleeding can occur because these are the sites where the vasa recta perforates the musculus externa, right? And this is the lumen, okay? And this is a site where the vasa recta perforates my externa, okay? So if a diverticulum is formed at this side, you can see the vasa recta will be perforated also, okay? And the bleeding can happen, right? So a GI bleeding can happen because of the injury to the vasa recta because of this outpouching, okay? So the patient can also present you with the iron deficiency anemia, right? If the bleeding is severe, then the patient can also have a shock, right? But most of the time they will present you with the iron deficiency anemia and the bleeding stools, okay? You will have the blood in the stools, right? And the iron deficiency anemia are uh, uh, the most common symptoms you will see in the diverticular bleeding, okay? And sometimes, okay, the obstruction to these outpouching can also happen, and whenever the obstruction happen, just like the appendicitis, you will have a diverticulitis, which is the inflammation of the diverticula, right? Because of increase in the interluminal pressure, right? You will get a compromisation in the blood supply, you will get the ischemia, you will get the necrosis, you will get the inflammation. So now let's discuss the diverticulitis, which is a complication of diverticulosis, okay? Again, you will see that in the old people only, right? It is basically the inflammation of the diverticula, okay? What you will see is the wall thickening first thing, okay? The locations is mostly the left sided because the sigmoid colon is the most common side where a diverticulitis happen, right? So the pain would be the left lower quadrant pain, okay? Because the inflammation is there, you will get the fever, you will get the high WBC like the leukocytosis count, right? And you will treat them with the antibiotics because the bacterial overgrowth will be happen in these locations. So you will treat the condition with the antibiotics also. The complications, first thing, because of the inflammation, the neutrophils would be there, okay? And when the neutrophils are there, they can lead to the abscess formation, right? If the inflammation is transmural, that can also lead to the formation of fistula, okay, and mostly it is the colovesical fistula, okay, and whenever a colovesical fistula happen, it will form a connection between the urinary bladder, okay, and the colon, right? In that case, you will also have a pneumaturia, right? Obstruction can happen, okay, because uh, you can also have the healing with the fibrosis sometimes, right? Or sometimes the inflammatory stenosis can also happen because of the overgrowth. Whenever there is inflammation, there is a hyperplasia, there is a wall thickening there, right? And this wall thickening can also lead to the obstruction. So whenever you get a patient with the acute diverticulitis, they can also present you with the constipation and the abdominal distension. On the endoscopy, you will see some kind of a obstruction. So do not confuse this with the cancer or with the tumor, right? Obstruction can also happen in case of diverticulitis. Okay, Stefan will try to trick you into this. Okay, they will tell you the patient is having some kind of obstruction, some kind of a mass is there, right? But you need to look for the other symptoms also. Then you will only choose the cancer. If the symptoms are more like diverticulitis, then you will choose a diverticulitis only, right? Even if the obstruction is present there. Okay, perforation can happen, right? And when the perforation happen, that can lead to the peritonitis. And when the peritonitis happen, the patient will present you with the guarding and the rebound tenderness, right? So initially the patient will having just a pain in the right lower quadrant. Okay, if the peritoneum is involved, then patient can also have the guarding and the rebound tenderness. So you will always have to palpate the patient's abdomen to make sure that the patient is not having a peritonitis in case of diverticulitis. Okay, very important. So depend upon the time of the disease. See, if you're having a very progressed inflammation, if the patient present you very late, then they can have a this fistula. Okay, but in the early stages, you won't have the fistula formation. Okay, the fistula will only present in the late stages when the inflammation is very much progressed or chronic, right? Not in the acute time.
Thank you.
Okay, so for the diverticulars, you first need to know what a diverticulum is. Okay, it is basically the outpouching that happens because of the increase in interluminal pressure. You need to know the type of the diverticulars, the true one and the false one. Okay, then you need to know about the diverticulosis, which is basically the many diverticulars in the GI tract, right? You need to know what people are most commonly affected, what site is most common, right? Uh, More than 60 years of age, these groups are commonly affected, and the location is commonly the sigmoid colon, right? The cause is important. What kind of diet can promote the formation of diverticulosis? It would be the diet which is low in fibers, okay, high in the fat and the red meat, right? And the patients who are having a history of this constipation or the obesity, they can have this condition, right? You will have to know the source of bleeding, which is a vasa recta. You will have to know the location or the point where the outpouching occur. It is the point where the vasa recta perforate the musculus externa, right? And then you need to know about the complications, which are first the bleeding. Bleeding is always painless. The patient will have a painless hematochezia, okay, as well as iron deficiency anemia. In case of any obstruction by the fecalith, the patient can also have a diverticulitis, which is an inflammation. Just like the appendicitis, it will present you as a pain in the abdomen. Nausea, vomiting would be there. The pain will be in the left quadrant, while in case of appendicitis, the pain will be in the right quadrant. Okay, and the fever, leukocytosis would be there. Complications are very important. Abscess you can get, fistula you can get, okay, and the obstruction and perforation you can get, right? So when you do the endoscopy of the patient, you can see these kind of the outpouchings and the connection with the lumen, right? This is the outpouching. As you can see in this figure, also in the diagram I've made, these are the outpouchings you will see, right? Very important. And yeah, any doubt?
No, thank you.
No, thank you.
Okay. We have discussed the colonic diverticulars. Now we need to discuss the esophageal diverticula, okay, which is a Sencker's diverticulum. Okay, it is also a false diverticulum, and just like the colonic diverticulum, it is also happened because of increase in the intraluminal pressure in the esophagus. right? And that happens because of a dysfunction of the cricopharyngeal muscle. Okay, you have the cricopharyngeal muscle, which causes the peristaltic movements in the esophagus, right? Whenever the dysfunction of this muscle happen, okay, like some kind of abnormal spasms, right? Okay, and this can lead to the dysphagia, right? And that increases the interluminal pressure. And because of this increase in the interluminal pressure, the patient can have a herniation of the oropharyngeal mucosa in the Killian's triangle. It is very important. The location of the Zenker's diverticulum is in, okay, and the triangle is made up by the thygopharyngeus muscle, okay, and the base of the triangle is made by the cricopharyngeus muscle. So whenever you have a dysfunction of the cricopharyngeus muscle, okay, the dysphagia will happen, okay, spasms will happen, and as a result, the interluminal pressure at the Killian's triangle will be increased, okay, and as a result, the outpouching of the mucosa and submucosa will happen, and that can lead to the formation of Zenker's diverticula, right? Now, what are the presenting complaints? First thing, of course, because of the muscle dysfunction, the patient can have a dysphagia, right? And the obstruction can also happen. As you can see, this is a mass present behind the esophagus. As the mass grows, as this uh, the diverticulum grows, it can also compress the esophagus, and that can lead to the obstruction and the dysphagia also, right? The aspiration will be there because of the dysfunction of the muscles and this diverticulum itself. Okay, all of the contents which are present in the diverticulum will be aspirated in the respiratory tract, and that can lead to a recurrent pneumonia episodes to the patient, recurrent aspiration pneumonia, right? The patient can have, okay, because of the food accumulation in this diverticulum, okay, foul breath can happen to the patient, okay, and it will present you as a neck mass. Most probably the lateral neck mass would be there, right? The patient will also have a sensation of food getting stuck in the throat, okay, which is actually happening, right, because of this diverticulum, right? Coughing and choking can also happen, right? So because of the food accumulation in the diverticulum, you can have an obstruction in the esophagus, dysphagia, okay, halitosis can happen, food regurgitation can happen, that can lead to the recurrent episodes of aspiration pneumonia or the recurrent episodes of lung sepsis. Okay, patient can have a chronic dry cough also, right? And foul breath will be there, neck mass will be there, and the dysphagia would be there. Yeah, that would be all about the Zenker's diverticulum. Okay, know the location, the Killian's triangle, know the muscle dysfunction, which is a cricopharyngeus muscle. Okay, know the cause, which is the increase in the interluminal pressure again. Okay, and then know the symptoms. Symptoms are because of increase in the accumulation of all these food particles in this diverticulum, and as a result, the size of the diverticulum will be keep on increasing. That will cause the obstruction symptom. The mass symptoms will be there, right? Regurgitation, aspiration will be there, and many other things. Okay, is that okay for the Zenker's diverticulum?
Yes.
Okay, so now comes the Meckel's diverticulum, which is the only true diverticulum in the body, right? It is a true diverticulum because it contains all the three layers of the GI tract. Okay, the mucosa, submucosa, muscularis, and serosa, right? It is basically the persistence of the vitelline duct, also known as the omphalomesenteric duct. Okay, and what does this duct do? Does anyone remember the function of omphalomesenteric duct? What does it do? No one?
It is the connection between the umbilicus and the ileum in the fetus.
Yes. Or
Yolk
you can say the
midgut.
yolk sac.
Hmm.
Yes, it is a connection between the yolk sac and the midgut,
Midgut.
right? So, and this is known as the omphallomesenteric duct. So, just before the birth, this connection need to be closed, right? And if the connection is not closed, then many complications can happen, and one of them is the Meckel's diverticulum, right? Other things, it can be a persistent connection between the umbilicus and the midgut, okay, and it is known as the Whittling fistula in that case, right? Very important. So Meckel's diverticulum happen, fistula can happen, right? And cyst can happen, the Whitland cyst, right? It can also happen. And yeah, that's would be it. So, yeah, the one of the complication is the Meckel's diverticulum because of the persistence of this Whitland duct or the omphallomesenteric duct. Okay, sometimes, okay, this Meckel's diverticulum can also contain other tissues, right? Just like the gastric mucosa or the pancreatic tissue. Now, because the gastric mucosa actually releases the acid, okay, it can damage the mucosa of this Meckel's diverticulum, and that can lead to the bleeding within the diverticula. Okay, and that's why most of the times the patient will present you with the painless bleeding. It would be a child, okay, and they will present you with the painless bleeding because of this gastric mucosa. And does anyone remember, if you found any tissue, any normal tissue in an abnormal location, what does it call?
Hematoma.
Not the hamartoma. Hamartoma is the abnormal kind of tissue, or you can say normal tissue with abnormal architecture in the normal location.
Choristoma.
Choristoma, yes. Don't forget that it is a choristoma. Okay. You can have a gastric mucosa in the Meckel's diverticulum. You can also have a pancreatic tissue in the Meckel's diverticulum, right? It can cause the hematochezia. Okay, we have discussed why. Because of the presence of the gastric mucosa, that will cause the release of acid. The acid will damage the mucosa there, right? And that can cause the bleeding complications, right? The patient can also have a right lower quadrant pain whenever the obstruction happened because of any fecalith, okay, or because of any kind of lymphoid hyperplasia, right? Because of the obstruction, the patient can have an increase in the pressure there, ischemia can happen, inflammation will happen, and that can produce a right lower quadrant pain. Okay, interoception can happen. Very important. Meckel's diverticulum is a very important cause or a pathological lead point for the interoception. Okay, volvulus can also happen. Okay, and obstruction can also happen, right? And the obstruction can lead to the right lower quadrant pain. Okay, so it would be sometimes a patient, okay, a child who is presenting you with the complaint of this bleeding stools. Okay, the parents will complain of the bleeding stools or the blood in the toilet paper. They will complain, right? They will complain about the fatigue, about the weakness, right? And when you check for the hemoglobin level, the patient will have a very low hemoglobin level in the labs, right? And the patient sometimes can also have a right lower quadrant pain, episodic type or maybe a very chronic type pain, right? And when you run the scan, and the most important thing, the most important scan that you can do is the 99 mtc per technate scan. Okay, and if you guys remember the similar scan we have discussed previously, the per technate scan. Yeah, exactly. Thyroid tissue. Okay, this scan can also locate the thyroid tissue. So you can use the scan for the gastric mucosa. You can use this scan for the location of thyroid tissue. Okay, you can use this scan in other areas also, not just these two, right? But you can detect other tissues also with the help of this scan, right? So you will inject this dye, okay, and wherever the dye goes, you will detect that this dye mainly detect your GI mucosa. So it will show two structures. One is the stomach, right, because it has a GI mucosa. Second is the Meckel's diverticulum, it will be shown, right, which is also containing the gastric mucosa. So you can diagnose with the help of this scan, right? And yeah, that's everything. And you need to remember the rule of two, that it is 2 times more likely in the male. It is 2 inch long and 2 feet away from the ileocecal valve. Okay, it is found in 2% of the population. Okay, very important. Two types of epithelium would be there, the gastric epithelium or it could be a pancreatic epithelium, right? You need to know why this is happening because of a persistence of the Whitline duct or the omphallomesenteric duct. What other complications can also happen because of a persistence of this duct? It could be a Whitline cyst, right? It could be a Whitline's fistula, right? Fistula can happen, cyst can happen, okay, and a diverticulum can also happen, right? So that would be all about the Meckel's diverticulum. Any doubt?
No, thank you.
Just note that it contains all the 3 layers. Okay. So now comes the Hirschsprung's disease, okay, which is a congenital megacolon. Now, what's happening? You have the neurocrest cells, and if you guys remember, we have discussed that the neurocrest cells, they will form the peripheral nervous system of your body, right? So every orbic plexus or the the mytic plexus or the Meissner's plexus that you see, right? They're all made up of the neurocrest cells, and neurocrest cells need to migrate into the GI tract, right? They will start migrating. They will first reach to the intestine, and from the intestine they will reach to the colon. From the colon they will reach to the rectum. Okay, so the last part to be colonized by the to be colonized by the nucleus cells is the rectum. Okay, now what happens whenever you have a disruption of the migration or any failure of a migration of these nucleus cells, right? Then you can have an absence of these cells in the GI tract in the colon, right? And that's how you can have a Hirschsprung's disease, because all of the cells are migrating from the ascending colon, then to the transverse colon, then to the descending colon. Okay, and let us suppose the disruption or the failure of the migration happens at the descending colon. Okay, so the ganglionic cells will be absent after the uh, or I can say the neurons, the orbic plexus, the Meissner's and the mytic plexus, they will be absent after this failure, after this area, right? So as a result, because no neurons would be there, so no mobility would be there, no secretion would be there. The patient will get the constipation first, right? And all of the food will be start accumulating in the lumen before the obstruction part, right? As a result, the dilation of that part will be occur. Okay, so after the obstruction, okay, everything is kind of narrowed, right? And before the obstruction, everything is dilated, and you will get the enlarged colon or the mega colon, I must say, because of the accumulation of food particles, because of increase in the pressure. The mega colon formation will happen proximal to the obstruction of the migration, right? Very important. So how does a patient present you? They will present you with the failure to pass the meconium, okay, within the 48 hours after the birth. After the birth, if the child do not pass the stools, okay, or the meconium, it is known as it can be a diagnosis of the Hirschsprung's disease. Okay, so the normal portion of the colon, which is proximal to the aganglionic segment, it will become dilated, okay, and result in the transition zone. Okay, and we have discussed that the Hirschsprung's disease is associated with the Down syndrome also. The patients with the Down syndrome, they can have a Hirschsprung's disease, right? And whenever you do the digital rectal examination, you can also see the explosive expulsion of the feces. Whenever you open the abdomen of the patient for the surgery, you can even see the explosive expulsion of the feces, because all of these feces will be accumulating before the aganglionic part, before the abnormal part, right? So whenever you cut open the abdomen, you will see the expulsion of the feces, right? And second thing, you can do the rectal biopsy. Okay, on the rectal section biopsy, you will see the absence of the ganglionic cells in the rectum, right? In the Meissner's plexus and in the mytic plexus, you will see the absence of the neurons, right? And that's how you know the patient is having the Hirschsprung's disease. You can also do the X-ray of the patient. X-ray will show the dilated loops, okay, before the obstruction, and after the obstruction, the loops are kind of very much normal or constricted, okay. And the step one will also ask you where should you do the biopsy, okay, whether in the dilated portion or whether in the constricted portion, right? So the biopsy must be done in the constricted portion. They will also ask you whether it could be a submucosa or the mucosa. So it would be the submucosa, because submucosa contain the neurons, not the mucosa, right? So you have to do the biopsy of the mucosa in the normal GI tract, right? In the normal GI or the colon portion, not a dilated portion, okay? Any doubt on Hirschsprung's disease?
No, no. Thank you.
And you can note one more fact, that this Hirschsprung's disease is also associated with the RET mutation, right? And rectum is always involved. Why? Because the migration happens from proximal to distal, and the last thing to be colonized by the neurical cells is the rectum. So whenever a disruption of migration happen, rectum will always involved. You will always get the rectum involvement, I must say, right? So yeah, that would be it. Any doubt? No? No? Any doubt?
No.
Now let's discuss the mal rotation. We have discussed that already, that the midgut, it need to be herniate outside the body. Okay, outside the body of the fetus, it will rotate to 90-degree, right? Then again, this midgut has to come back to the body, to the abdomen, right? And again, it will takes 180-degree of the turn, right? It will rotate 180-degree in the counterclockwise. So a total of 270-degree counterclockwise rotation happen. Okay, and the rotation is happening around the superior mesenteric artery. Whenever the rotation is inhibited, right, you will have the improper positioning of the bowel. Because of inhibition of the rotation, you will have the improper position of the bowel. Okay, the colon will be present in the left side, and the intestine, the small intestine, will be present in the right side, right? Then you will also have the absence of the peritoneum. Okay, and the mesentery, I must say, you will have the absence of the mesentery, and the mesenteric base will become very much narrowed. Okay, you will have the formation of fibrotic bands between the colon and the liver, right? And these bands, they can also include the duodenum, so you can have a duodenal obstruction also, right? That can present you with the constipation, with the with this what do you call it, the swelling. Okay, you will have this. And yeah, because of the narrowing of the base of the mesentery, this bowel loop, okay, can rotate around itself, can turn around itself, right? And that can lead to the formation of volvulus. So a complication could be the volvulus. Okay, complication could be the duodenal obstruction because of these lad bands or the fibrotic bands which are forming between the liver and the colon, the transverse colon, right? Normally, the cecum is present in the right lower quadrant, but in case of malrotation, the cecum is present in the right upper quadrant, as you can see. Normally, the cecum is in the right lower quadrant, but in case of malrotation, you can also have the cecum in the right upper quadrant. Okay, the patient will present you with the bilious vomiting because of urinary obstruction. Okay, bilious vomiting would be there, abdominal distension would be there, constipation would be there. Okay, when you do the laparotomy, you will see the fibrotic bands which are extending from the colon, okay, to the uh, retroperitoneum, right? Very important. And because these fibers, they passes a duodenum, you can have a compression of the duodenum also, right? Very important to note. That would be all about it. Okay, so this is a malrotation. It happens whenever your midgut fails to rotate around the supramesenteric artery. As a result, abnormal positioning of the bowel happen. Okay, the colon will be on the left side, and the small intestine will be on the right side completely. Right, you will have the fibrotic bands that can cause the obstruction to the duodenum, that can cause a constipation, bilious vomiting. Okay, and the abdominal distension, of course, you will have, right? And yeah, that would be all. Any doubt on the malrotation?
I have one question.
Yes.
Could you please explain what it means from retroperitoneum, like fibers are extending from the colon and cecum to the retroperitoneum? What does that mean?
See, behind these bowel loops, okay, you have the retroperitoneum, which is a kind of layer you can see. Just like the peritoneum, it is a membrane-like structure, which is present behind the small bowels or the this colon, right?
Yeah.
So if I draw the diagram, if this is your colon, okay, normal type structure, okay, this is a colon normally, okay, you have this a base of the mesentery, you can say, okay, and this base of the mesentery is the peritoneum known as a retroperitoneum, right?
Yeah.
It is work as a base. for the small bowels. Now, all of the small bowels will be present over this retroperitoneum only, right? All of the small bowels will be on this retroperitoneum, right? And whenever the malrotation happens, this retroperitoneum will be kind of disrupted. Okay, it will have a very narrow base. As you
Yeah,
can
yeah.
see, initially the base is very much broad, but in case of this malrotation, you will have a very narrow base. Okay, and this uh, this retroperitoneum, it actually stabilizes the small intestine, right? But when this structure is kind of disrupted, okay, whenever the base become very much narrowed, okay, this loop of the bowel can also twist upon itself, and that can lead to the formation of volvulus. Okay,
Yeah, yeah.
so
Okay.
this yeah, so this retroperitoneum is nothing but the which some fibrotic structures, or you can say the peritoneum, okay, which is forming a base for the small intestine, right? It will provide the stability to the small intestine.
Okay. Thank you.
Okay, then comes the interoception, okay, which is a telescoping of the bowels. Okay, the proximal segment of the bowel, it will be telescoped into the distal segment of the bowel. As you can see here in the figure also, this is the proximal segment, this is a distal segment, and the proximal segmented is this segment is that telescoped into the distal segment. If I draw the diagram, it will be seen like that. This is a distal segment which is kind of dilated, okay, and the proximal segment is telescoped within the distal segment, just like that, right? This is known as the interoception. Okay, most of the time, most of the times the interoception is idiopathic. Okay, but sometimes it can also be associated with the lead points. Okay, secondary to the lead points. Most of the time it is primary, it is always idiopathic, right? But sometimes it can be also associated with other lead points. Okay, and let me discuss these lead points for you. The most common pathological lead points is the Meckel's diverticulum in the children. Okay, in the children it is the megacervaticulum. In case of adults, okay, it would be the tumor or any kind of mass in the GI lumen. Okay, whenever a mass is present, it can cause the interoception in case of adults. In case of children, okay, which are more than 2 years of age, very important, more than 2 years of age, the macros diverticulum is the most common pathological lead point for the interoception, right? For the children who are less than 2 years, okay, uh, uh, you know, no specific cause is given. Okay, it is always the idiopathic in case of children less than 2 years of age. Okay, but sometimes they can also be associated with the viral infection. Very important. So for children below 2 years of age, it could be idiopathic, it could be associated with a viral infection. Okay. For the children more than 4 years of age, okay, the most common pathological, more than 2 years of age, the most common pathological lead point would be your macros diverticulum. In case of adults, the most common pathological lead point would be any kind of tumor or any kind of a mass in the GI lumen, right? These are the causes. Now, what you will expect in the interoception, the patient will present you with the nausea, vomiting, constipation sometimes, right? So nausea, vomiting, constipation, fever, right? And the patient will also get the current jelly stools, which is a the blood tinged stool. Okay, because the blood supply to that area will also be compromised. The ischemia, necrosis can happen, bleeding complications can happen, and that can lead to a stool which is rich in the blood. Okay, so a blood tinged stool you will get, which is also known as the current jelly stools, right? So a pain, nausea, vomiting, constipation, abdominal distension, fever, okay, and this the red stools or the current jelly stools. These are the symptoms for the interoception. Okay, when you do the examination, you can see the olive shaped mass in the ultrasound because you are looking from this side. Okay, if I draw the diagram again, in the ultrasound you are looking from here, right? That okay, like that here. So it will be seen as the small segment and the dilated segment. They will be seen like that. Okay. So this segment will be telescoped within this dilated segment, right? So it will be appear as a target kind of sign. Okay. So this would be seen in the interception. The pain will be the right lower quadrant pain, because most of the times, right, the most common location for the intersection is the ileocecal junction. And can anyone tell me why the ileocecal junction is the most common location for the intersection?
Size between the ilium and the cecum.
Yes, the cecum is much more dilated than the ilium. Yeah, so this proximal segment of the ilium will be telescoped within the cecum, right? And because these structures are present in the mostly in the right side, right? So you will have a right lower quadrant pain, right? Very important to note. You will have a right lower quadrant pain, and they will ask you why, because of the ileocecal junction involvement, right? And on the CT or on the ultrasound, you can see the targetoid sign or the target sign. Okay. Now, the other causes or the associations of the interception, they includes the IG, avasculitis, or the Henoch-Schönlein purpura. You guys remember if okay, IG vasculitis can lead to the interception, and that's why in the IG vasculitis you're having this pain, nausea, vomiting, diarrhea, right? Because of the interception also. You can similarly having this after the recent viral infection, okay, which could be the with the which could be with adenovirus, could be with the other viruses also, right? And that can lead to the Peyer's patches hypertrophy. And where does the Peyer's patches located? The location of Peyer's patches.
Ilium.
Ileum. Okay. And what does the Peyer's patches do in the ileum?
Immunity.
Immunity, right? So whenever you have a adenovirus infection or any other virus or parasitic infection, you will have the hyperplasia or the hypertrophy of the Peyer's patches. As a result, they will form some kind of a mass, right? And you guys already know whenever you have a mass, you can have the intersusception in case of adults. In case of children also, whenever you get the infection with the bacteria, with the virus, you can also have the intersusception. Okay. So any doubt on intersusception?
No.
Then you have the volvulus, which is a twisting of a portion of the bowel around its mesentery. You have a base, you have a mesentery, okay? And whenever a loop of bowel or a bowel arch, okay, loops or twisted around itself, right? This can lead to the formation of volvulus. Okay, very important. And so it can happen throughout the GI tract anywhere, right? But the midgut volvulus is more common in the children, and the sigmoid volvulus is more common in the adults. So now you can tell me, where does the pain of this volvulus happen in adult?
Hypogastric region.
Yeah, where in the hypogastric lesion? You have two hypogastria.
Umbilical region.
Where? Where?
Umbilical region. Umbilical region around umbilicus.
Not the umbilicus. You're having an involvement of sigmoid volvulus. See, sigmoid colon is involved most commonly, right?
Left.
Yeah, exactly. The left side. You will have a left side pain in case of sigmoid volvulus because of the location there. Okay, and it is seen in the senior adults mainly. And what you will see is the coffee bean sign. As you can see, this is a coffee bean sign you will see in the volvulus. In case of children, because the midgut volvulus is kind of common, you can have mostly the right-sided pain, right? In case of sigmoid volvulus, you will have a left-sided pain. Okay, very important. And yeah, so that would be all about the volvulus. You will have the twisting uh, of the bowel around its mesentery, and as a result, the blood supply to that part will be compromised. right? And as a result, you will have the ischemia, you will have the infarction, right, in that area, and that will produce you the pain. So what is the treatment of the volvulus?
Surgery.
You will do the surgery to basically relieve this volvulus first. Okay, if the volvulus is kind of reversible type, okay, you will try that first. If it become irreversible, if the necrosis happened to that part, then this part will become very kind of waste now, right? So you have to do the bowel resection. Okay, if the necrosis happened, then you have to do the bowel resection, but initially we'll try to kind of reverse this thing, right? Very important. So now, any doubt on the volvulus?
I have one question. It's not from
Okay.
volvulus. I'm just speaking generally. Uh, do we get ultrasound images in the main exam?
No, you won't get. Don't worry about that.
Okay, and nothing from echocardiography also, right?
No, don't worry about that also.
Okay, thank
It is
you.
kind of very higher stuff. Okay, it's not for our level, so you won't get it. What you will get is the X-ray, CT scans mainly, not the ultrasounds. But you have to remember 2-3 ultrasounds, like the one for the gallbladder, okay, and the one for this the intercessor. Okay, only 1 or 2 you will have to remember. You won't get otherwise.
Okay, thank you so much.
Okay, so any doubt up to the volvulus?
No, thank you.
So now you need to know about the other intestinal disorders, and the first is the acute mesenteric ischemia, and this happens whenever the blood supply to your intestine are lost, right? It generally happens because of a embolic occlusion of the superior mesenteric artery, and whenever you have an acute occlusion, sudden occlusion, that can lead to the necrosis, right? And if you have a chronic occlusion, then what happens?
Necrosis.
In case of chronic one,
Sorry, can you
remember
repeat the question?
if you have a chronic obstruction, let's just say atherosclerotic plaque, okay, for example, then what will you have? In case of
Ischemia.
embolism, yeah, you have ischemia, and then does a necrosis happen?
Yes.
Oh, are you sure?
If blood supply is going to hamper to the organ, it definitely will result in ischemia and
Only if the 100% of blood supply is lost, right?
oh, yes.
In case of partial obstruction, I'm talking about. Remember the chapter, the adaptations we have discussed. Whenever you have a chronic stress or a slow progressing stress, okay, the cells will try to adapt to that environment, right? So adaptation will happen, and because of loss of blood supply, you will have the atrophy, right? But whenever a sudden the loss of blood supply happen, okay, very suddenly, then your cells won't get the chance to adapt, right? And when they won't get the chance to adapt, then the necrosis will happen. Okay, so because of the embolism, because it is a sudden occlusion of the superior mesenteric arteries, okay, your midgut, it won't get the chance to adapt, right? And as a result, the small bowel necrosis will happen. Is that okay?
Yes.
Yes.
Now, can you tell me in what patients I can expect an embolism? What history of the patient could be present?
Hypercoagulable state, maybe a patient who is prone to get clots, like a person using OCP, or a person
If the
who,
person is using the OCP, then they will have a deep vein thrombosis, right?
yes.
So that can cause the lung infarction or the systemic infarction.
So
MI patients.
Atrial fibrillation.
Fibrillation, yes. Whenever you have an arrhythmia, you can expect an embolism. If you guys remember, you always have to give the patient anticoagulant therapy, like the heparin or the warfarin. Remember?
Yeah.
So one cause is the arrhythmia. Second cause,
DIC, disseminated intravascular coagulation, microthrombitis, and embolisms. Okay.
yeah, but because they're kind of very much micro ones, so yeah, not the major thing. But yeah, you can expect very small
Malignancy also.
ischemias.
Yeah,
Malignancy, yes.
microthrombi, no, yeah, ischemia will not cause. Malignancy is also hypercoagulable stage, might
Yeah,
can cause.
yeah, they can bust, but mostly they will also cause the vein thrombosis, not the artery thrombosis.
ASD,
Okay.
What?
AS in
AS?
ASD, like from this then circulation to arterial through its
Actually, your voice is very much interrupting. If you please repeat it again.
atrial septal effects, ASD.
I'm not understanding. You can write in a chat box, please. Oh, ASD. It is yes. In case of ASD or in case of this, the persistent foramen ovale, you can have a paradoxical emboli, right? So in that case, you can have this acute mesenteric ischemia, right? In case of myocardial infarction, if you guys remember, whenever you have a MI, okay, you will have the aneurysm formation, right? And because of the aneurysm formation, you can also have the embolus formation. Is that okay? MI?
Yeah.
In case of atherosclerosis, if you have a systemic atherosclerosis, then in that case, the you know the thrombosis can happen in the atherosclerotic plaque, right? And then it can also become the embolus, right? And that can lead to the acute mesenteric ischemia. Is that okay?
Yes.
Yeah, that's fine.
Any other cause?
Myxoma, detachment
Yeah,
of myxoma.
myxoma can happen. Very good. Yeah, myxoma can happen. Similarly, endocarditis can also happen if the endocarditis is on your left
Yes,
side, right? So
endocarditis.
always remember, these are the kind of history the patient will present you. They will present you with the history of dyslipidemia, and from the dyslipidemia, you can check. You can think of, you can think about the atherosclerosis. Okay, if the patient is having a atherosclerosis anywhere in the body, okay, then it can become the embolus. It can cause the AMI, right? If the patient is having a myocardial infarction, then they can also have a AMI, right? If uh, if the patient is having any kind of arrhythmia, then you can also expect the AMI in these patients. So that, okay, so these are the kind of histories the patient will present you with. Okay, because of sudden blockage in the supramesenteric artery, which is the most common time, okay, you will have the small bowel necrosis, and they will present you with the abdominal pain, which is out of proportion of the physical findings. Okay, you will have the necrosis, you will have the edema of that area. Okay, when you do the laparotomy or when you do the endoscopy of the patient, you can see the necrosis, you can see the edema over there. Okay, you can see the tenderness over that area. Okay, so yeah, that would be the acute mesenteric ischemia. Any doubt?
No, thank you.
Just the fever and the pain mainly. Acute onset of fever, acute onset of pain. On the laparotomy, you will be seeing the edema over the area, wall thickness would be there, necrosis would be there, right? That's how you know the patient is having a acute mesenteric ischemia. Okay. And the pathophysiology for the AMI as well as the myocardial infarction is absolutely same, because in both the condition you are having a thrombosis and the embolism, right? So kind of same pathology between the these two. Now, second one is the adhesions. Okay, adhesion is basically a formation of any scar. Okay, whenever you have a transmural inflammation, that can lead to the formation of scar. The fibrosis can happen, right? And whenever the fibrotic bands form, they can cause the obstruction, right? So it is a formation of fibrotic band of scar tissue. Most commonly, these adhesions happens after surgery. Whenever you do the surgery, the bowel surgery, okay, and when the healing occur, okay, the healing can lead to the formation of scar, and that can lead to the formation of fibrotic bands that can cause the obstruction, right? Whenever the obstruction is there, the patient can have a constipation, the patient can have a nausea, vomiting, okay, and the patient can also have a abdominal distension. So a patient with vomiting, nausea, abdominal distension, constipation, that means obstruction is there. Obstruction along with the recent history of inflammation or a recent history of surgery, it will make you think about the adhesions. Okay, what you will see is the multiple dilated small bowel loops on the X-ray. You will see the multiple dilated loops of bowel on the X-ray because of the the food getting filled in these areas because of the obstruction, right? So they will become very dilated. The pressures are rising in these areas, so they will be very dilated. Is that okay about the adhesions?
Yes.
Then comes the angiodysplasia. As the name suggests, angio means the blood, dysplasia means a abnormal growth. Okay, so this kind of a abnormal growth of the blood vessels. It is a tortuous dilations of the blood vessels, right? And because the blood vessels are involved, that can cause the bleeding and that can cause the hematochezia. The bleeding stools would be there, right? And once you do the endoscopy of the patient, you can see these cherry red lesions in the colon. Okay, remember the right-sided colon is the most common locations for the angiodysplasia. So when you do the colonoscopy, okay, when you do the colonoscopy, you can see the cherry red lesions in the right-sided colon, right? It is more common in the older patients, right? They could be associated with the end-stage renal diseases. They could be associated with the von Willebrand disease and could be associated with the aortic stenosis. Okay, so a patient with a history of painless GI bleeding, okay, of course, it would be a very painless GI bleeding, or the patient can also have iron deficiency anemia because of the bleeding, right? Along with these things, the patient is presenting you with the, one of the three histories, either the chronic kidney disease or the von Willebrand disease or the aortic stenosis. Okay, that means the patient is having a angiodysplasia. Then comes a chronic mesenteric ischemia, in which you are having an intestinal angina, which is same as the angina of the heart. You are having an atherosclerotic plaque. Okay, it could be in the celiac artery, it could be in the superior mesenteric artery, it could be in the inferior mesenteric artery. Okay, because of the presence of this atherosclerotic plaque, you are having an intestinal hypoperfusion. Okay, and whenever the supply demand mismatch occur, okay, like after the food, you need to increase the blood supply to the intestine, right? And why? Because of the increase, yeah, because of the increase in the oxygen demand, right?
Yes.
So you need to fulfill these demands by increasing the blood supply. But in case of atherosclerosis, you're not increasing the blood supply much more, right? And as a result, the supply demand mismatch occur, and that can lead to the postprandial epigastric pain. Depending upon which artery is involved, okay, you can have the epigastric pain, you can have the paraumbilical pain, you can have the hypogastric pain also, right? And because of this postprandial pain, the patient will also develop the food aversion. Okay, he become very afraid of the food. He don't eat the food, right? Because they know whenever they eat food, they will have this abdominal pain, right? So they stop taking food. They will have the weight loss. So a weight loss, a food aversion, okay, a chronic postprandial pain, or any history of the atherosclerosis anywhere in the body. Because once you have atherosclerosis anywhere in the body, you can again have this plaque in other parts also, right? Or the patient with a history of diabetes could be there. Okay, a patient with a history of dyslipidemias. Okay, they can also have this atherosclerosis, right? So hypertension, dyslipidemia, diabetes, old age, these are kind of a risk factors for the chronic mesenteric ischemia. The pathophysiology will be similar to the angina of the heart. Is that okay?
Yes.
So now comes the colonic ischemia, okay, which is reduced in the intestinal blood flow, of course. You will get the crampy abdominal pain followed by the hematochezia, okay, and the watershed areas are involved. Whenever you have a diffuse loss of blood supply, okay, and please note that both the superior mesenteric artery as well as the inferior mesenteric artery, they must need to be blocked in order to get the colonic ischemia. Yeah. Why? Because if you block the inferior mesenteric artery, then superior mesenteric artery can provide the circulation. If you block the superior mesenteric artery, then inferior mesenteric artery can provide the circulation. So you need to block both the arteries to get the colonic ischemia, and the watershed areas will be affected first. Okay, you will have the splenic flexure and you will have the rectosigmoid junction. What you can see is the crampy abdominal pain after the eating. Okay, you can have the hematochezia also. Okay, you will have the edema of the mucosa. You will have the wall thickening. You will have the hemorrhage. Okay, yeah, that would be all about it for the chronic ischemia. Any doubt? Any doubt?
No.
Now comes the ileus. Okay, it is basically the hypomobility of the intestine, or I can say the paralysis of the intestine. It is known as the ileus, right? And because of the hypomobility, you can have the constipation. Okay, you can have the distension of the abdomen because of accumulation of the food, right? You will have a decreased bowel sounds. Whenever you have a diarrhea, okay, step one will tell you the patient is having an increased bowel sounds, and the increased bowel sound is the way of telling them to you that the patient is having a diarrhea, right? If you're having a decreased bowel sounds, that means the patient is having a constipation, right? It could be associated with the abdominal surgeries because you give to some, the neuromuscular blockade agents, or some spinal anesthesias could be given, right? So they can cause the post-operative paralytic ileus. Okay, so it could be seen after the surgery, right? It could be seen after the opiates, right? It could be seen after the hypokalemia, after the sepsis because of loss of blood supply. The hypomobility would be there, right? Treatment will be to provide the patient bowel rest. Electrolyte corrections could be given, and the cholinergic drugs, which are the muscarinic agonist. And does anyone remember any name?
Methacol, methacholine.
Yeah.
Pilocarpine.
Pilocarpine, yes. Methacholine, pilocarpine. Ethanol is mainly for the urinary bladder, okay? But you can also give that drug in here, right? So these are the agents you will give for the paralytic ileus. Then you have the meconium ileus, okay? Meconium ileus happens whenever the meconium become very hard and it blocks your intestine, okay, or the colon, okay? Whenever your stools become very much hard, okay, very much dehydrated, very much hard, okay, and they will block the intestine, that can cause the meconium ileus, and it is seen generally with the cystic fibrosis, because you guys know in cystic fibrosis I'm having a dehydration of the stools, right? The stools will become very much hard, similar to other body secretions like the bile secretion or like the pancreatic secretions. Okay, they will become very dehydrated, right? And as a result, you will have the obstruction of the colon, or the obstruction of the ileum. So you will have the abdominal distension, you will have the constipation, you will have the nausea, vomiting, okay? And the presence of stool would be seen uh, on the examination, right? So that's how you know the patient is having a meconium ileus, okay? And yeah, that's all about it. The patient will also have the bilious emesis, okay? And the patient will have a normal rectal tone, because you guys know that the obstruction-like symptoms will also happen in the Hirschsprung's disease. You will have the dilated bowel loops in the Hirschsprung's disease. You will also have the dilated bowel loops in the meconium ileus also, right? So in order to differentiate between two conditions, you need to do the rectal section biopsy, okay? If the normal biopsy is there, that means the patient is having a meconium ileus. If the biopsy is abnormal, then the patient is having the Hirschsprung's disease. Okay. And yeah, that would be all about it. Any doubt?
Can you explain what is this meconium plug is of actually?
What does this?
Meconium plug is, what is it actually? I mean, what is the
Stool,
composition of it?
dehydrated stool.
It is only in infants, newborns.
See, meconium is the first stool the infant passes. Okay. The first stool that infant passes, this is known as a meconium, right? But in case of a cystic fibrosis, they're having a very dehydrated stool. And this meconium, the first stool, it will block the lumen, right? And that can cause the obstruction. Similar to that of Hirschsprung's disease, you have the presentation of the disease within 48 hours, right? In case of meconium ileus, you can also have the presentation of disease within the 48 hours by the constipation or by the failure to pass the meconium, because the meconium is kind of blocking the path, right?
Yeah, and it is only present in cystic fibrosis.
Yeah, only in the cystic fibrosis, yes. A very
Is there any
specific to it.
association with Down syndrome and hypothyroidism?
Meconium ileus in the Down syndrome and the hypothyroidism.
Yeah.
Oh no, I'm not sure about that.
Okay. Okay. Thank you.
But I've just heard about the cystic fibrosis only. In the U world also, they have mentioned the cystic fibrosis part, not the other syndrome. So yeah, not sure.
Okay, thank you.
It is actually happening because of the dehydration of the stool. Okay, and the stool is kind of become very hard, very stony, so that it can block the lumen. So anything which can cause the dehydration, they can cause a meconium ileus. Okay.
Yeah, okay, I got the point. Thank you so much.
Okay, now comes a necrotizing enterocolitis. The first thing you need to remember for the necrotizing enterocolitis, okay, is it is only seen in those infants, okay, which are on the formula feed milk. Okay, those infants who are on the formula feed milk, not the natural breast milk. Okay, only in these individuals, only in these neonates, they can have the necrotizing enterocolitis. And the second thing, the neonate must be a premature one. Okay, so two things must be there. First thing is the prematurity, and second thing is the formula feed infant. Okay, they can have the necrotizing enterocolitis. Why? Why? What happens actually is because they have born before the gestation weeks, right? So they have a very immature immune system, right? But as soon as they, sorry, as soon as the birth of these infants occur, okay, their GI tract will be colonized by the bacteria, but the immune system is not there to check the proliferation of these bacteria, and as a result, the hyperproliferation of the bacteria will occur. And because of the hyperproliferation, you can have the damage of the intestinal walls, right? And because of the damage of the intestinal walls, because of the necrosis, right, you can have the air in the bowel wall. Very important, the air in the bowel wall, you can have the abscess in the bowel wall, you can have, right? The necrosis will happen, right? And most commonly it affects the terminal ileum and the proximal colon. Sometimes the perforation can also happen, and when the perforation happen, it can lead to the peritonitis also, the guarding and the rebound tenderness, right? You will have the pneumoperitoneum, which is air in the peritoneum, right? Free air in the peritoneum. You can also have a portal venous gas. Okay, the gas in the portal venous system you can have, right? So it would be a ischemic necrosis because of the bacterial overgrowth. Why? Because the immune system is immature, because the patient is born pre-birth, okay, prematurely, right? So they will have a very weak immune system. They will have a hyperproliferation of the bacteria that can cause the necrosis of the wall of the intestine. You can have a air in the bowel wall, you can have the air in the peritoneum, you can have a air in the venous system, okay? And how will step one tell you? They will tell you about the curvilinear areas of lucency. As you can see there, okay, as you can see, the walls are very much kind of differentiated from one another, right? And you can see the air filled areas. So these are the curvilinear areas of lucency. Okay, and this is a way of the step one to describe about the pneumatosis intestinalis, which is the air in the bowel wall. Is that okay?
Yeah.
And if I draw the diagram for you, see, this is a normal bowel wall, and that would be seen in the X-ray also, right? Like this. In case of pneumatosis intestinalis, what happens is the air will be present between the bowel wall, right? So it will be seen like this. Okay, and this whole area will be filled with the air. Okay, so two layers of one wall will be seen in the X-ray. That's how you know the patient is having a pneumatosis intestinalis. This is known as the curvilinear areas of lucency that will be described, right? Okay. Is that okay?
Yes, yes.
So this is the necrotizing enterocolitis. Okay, one thing is the prematurity. Second thing is the formula feed infant. Third thing is the air within the bowel wall. Okay, the location will be the ileum or the colon, right? Necrosis can happen, pneumoperitoneum can happen, okay, and the portal venous gas can happen. This is all about the necrotizing enterocolitis.
It's air in the bowel wall or bowel lumen?
Bowel wall, because of the necrosis, the air will be leaked within the bowel wall. Okay, that's why you're seeing two different, if I draw that again, see, this is a normal scenario, okay, and this is the scenario for the necrotizing enterocolitis. You will have the air between the bowel wall, right? So it will be seen as the splitting of the wall, as you can see. This splitting of like thing will be seen, right? This is the curvilinear areas of lucency. They will describe it like that, okay? The area in the bowel wall itself, not in the lumen. Is that okay?
Okay, okay. Thank you.
Okay, so 3-4 facts, please remember about the necrotizing enterocolitis. They will always describe a premature birth along with the formula feeding facts. They can ask you the cause of it because of the immature immune system, okay, and the hyperproliferation of the bacteria. They will ask you about this pneumatosis intestinalis, which is air in the bowel wall, right, and the curvilinear areas of lucency. They can ask you about that. They can ask you about the complications, right? That should be all about it. So, any doubts so far on this page?
No, thank you.
Okay, so we will take a short break and then we will start the colonic polyps and the cancer, okay?
Okay.
Okay.
And now let's discuss the polyps, okay? Polyp is basically a growth within the lumen of the colon, right? Colonic polyps are the overgrowth, you can say, or an outgrowth within the lumen of the colon. See, the things about the diverticulum is that they are the outpouching, okay, and they happen outside the lumen, right? But about the polyps are basically forming within the lumen, right? There will be a mass which is projecting inside the lumen, right? These are the polyps. The polyps could be flat, the polyps could be sessile, the polyps could be pedunculated, okay? And we have discussed them. And so we have two type of polyps, okay? One, those have the neoplastic potential, right, or the malignant potential, and the second ones that those uh, that cannot form any cancer, right? So first one are the non-neoplastic ones, which are kind of benign lesions, okay? They can never progress to the cancer. And the second ones are those which have the malignant potential. Okay, so first one is the hamartomatous polyp. Okay, hamartomatous polyp happens whenever a normal tissue, the architecture of the normal tissue will become very disrupted. Okay, and the tissue is found in the same location, right? So this is known as a hamartoma. A hamartomatous polyp contains every single layer of the GI tract of the colon, right? It will contain the mucosa, it will contain the submucosa, it will contain the crypts, it will contain the serosa, right? But in a distorted manner. Okay, so polyp will contain the similar structures, same cells, okay, benign lesion, okay, but it is completely distorted. This is known as the hamartomatous polyp. Now you have two conditions or two syndromes associated with the hamartomatous polyp. One is the PJ syndrome, okay, and second is the juvenile polyposis. Okay, for the PJ syndrome, it is an autosomal dominant mutation, okay, in which you have a numerous hamartomas throughout the GI tract. Okay, you're gonna have a numerous hamartomas throughout the GI tract. Okay, along with the hamartomas, you will also have the hyperpigmented macules on the mouth, lip, hands, and genitals. So whenever you encounter a patient having many polyps, okay, along with the hyperpigmentation in the mucosa, on the lip, on the oral mucosa, right? That means the patient is having a PJ syndrome. Very important, right? And the patient will be having an increased risk of developing the GI cancers and the breast cancer. And that's why you need to do the bowel resection in these patients. Okay. The second is the juvenile polyposis syndrome, in which the polyposis, the multiple polyps, numerous polyps, okay, they are formed in the colon of the patient, and it generally happens in the children who are less than 5 years of age. Okay, it will happen to the children less than 5 years of age. The patient will develop the numerous hamartomatous polyps throughout the colon. Okay, and the patient will be having an increased risk of colorectal carcinoma. So two things or two syndromes with the hamartomatous polyps. Generally, if it is solo lesion, then the solo lesion will always be benign. Okay, you do not need to operate on the patient. You have no need to do anything for that, right? But if the patient has multiple polyps, multiple hamartomatous polyps, then then the patient will be having an increased risk of developing the cancer. And in that case, you need to remove the polyps or to remove the bowel segment, right? So two syndromes, the PD syndrome or the juvenile polyposis syndrome. These two things can happen. Is that okay about the hematomatous polyp?
Yes.
Please remember, you will have a normal tissues, okay, but a kind of a very distorted manner, right? Architecture will be very abnormal, but everything will be normal, okay, other than that. Second one is the hyperplastic polyps, okay, and they generally happens in the rectosigmoid junction. Very important. These are the most common type of polyps, okay, and these are most commonly present in the rectosigmoid junctions. Okay, sometimes they can also evolve into the serrated polyps, and when the serrated polyps form, they can cause the cancer. Okay, you will have a sawtooth pattern, okay, and the serrated pattern in the hyperplastic polyps. As you can see, uh, given here, it's not given. Let me open up the histology for the serrated polyps. Give me a second. See, whenever you have a normal architecture, okay, all of these things are seeing, these are the crypts. Okay, these are the crypts that you are seeing here, right? A normal crypt would be like that in a very circular manner. Okay, this is a structure of a normal crypt. Okay, and these are the cells in the crypt. Okay, in case of a serrated polyps, okay, instead of this structure, you are having some kind of a starry pattern of the crypt. Okay, this is a crypt in case of a serrated polyps. As you can see, you're having so much branching like structures within the crypt. Okay, and some of them are the star like structures, as you can see, right? So whenever you have this type of appearance of a crypt, then you can immediately know that the patient is having a serrated polyps. Normal, they're very regular, they're very circular, right? But in case of a serrated polyps, these crypts will become very branched. Okay, they will have this sawtooth-like appearance, which will show you again. Don't worry about that. Okay, and you have this type of starry sky. Okay, you have this star-like pattern of the uh, of these crypts. Okay, the branchings will be present. Okay, so these are the hallmark feature of a serrated polyps. These branchings and this star-like pattern of the crypts, like, and the normal crypt will be like that. As you can see, this is the normal crypt. Okay, it is very much circular. Okay, regular, not the very much branched. But if it is branched, then it is a serrated polyp. Is that okay? The histology.
Yeah. Yeah.
Yes.
Okay, so whenever you encounter this kind of histology, this kind of projections are there, this kind of crypts are there, that means it is a serrated polyp. That's exactly you will see in the hyperplastic polyp also. Okay. And please note, this is the most common type of polyp in the human, right? Hyperplastic polyp. Okay, and other thing is, the location is very important. Whenever you have this kind of a structure, the serrated polyps type thing in the rectosigmoid junction, that means it is a hyperplastic polyp only. Okay, and they're kind of very much well differentiated. Okay, and the cells will be forming the glands, the cells will be forming the crypts. Okay, I have shown the structure of the crypt. Normally it is kind of very much glandular type, very much circular. Okay, but in case of a hyperplastic polyp, the crypts will become very much branched. Okay, very much star-like. Okay, then comes the inflammatory pseudopolyps, which happens in the inflammatory bowel diseases because of the regeneration of the mucosa. Whenever the regeneration of the mucosa happens, sometimes the overgrowth can happen in that area, right? And because of this overgrowth, you can have a pseudo polyps, and these are known as the inflammatory pseudo polyps. Okay. And once you do the biopsy, everything will be absolutely normal. All of the layers are present in the normal regular fashion, right? And these are the inflammatory pseudo polyps. The patient will be having a history of mostly the ulcerative colitis. You will see the inflammatory polyps mostly in the ulcerative colitis. Then you have the mucosal polyps, okay, in which you have the mucosa only, no submucosa, no muscularis. You just have the mucosal part, the epithelial part only, right? And these are the mucosal polyps. For the submucosal polyps, you can have either the lipomas, you can either have the leiomyomas, you can either have the fibromas. So once you do the biopsy, you can either see the fibrosis, you can either see the word-like appearance of the smooth muscles, the leiomyomas. You can either see the fat cells only within that polyp. That means it is a lipomatous polyp. Okay, so these are all the benign polyps. Any doubts so far in the benign polyps?
No, thank you.
Now then comes the malignant polyps, all the polyps which have the malignant potential, and they can cause the colorectal carcinoma, right? The first one is the adenomatous polyp. Okay, the adenomatous polyp forms whenever a mutation in the APC occur. Okay, the APC gene is present, which is a tumor suppressor gene. Whenever the mutation occur, the overgrowth of the mucosa and submucosa, all these layers will happen, right? And they will form a adenomatous polyp. The polyp will be very much small after the mutation, right? Then the second mutation occur, and which is the KRAS mutation, which is the proto-oncogene mutation. And as a result, the size of the polyp will increase. Okay, the polyp will become more than 4 centimeter in the size. And now this polyp is having a very high malignant potential. Okay, if one more mutation, which is a TP53 mutation, occurs, then it can form the colorectal carcinoma, right? You have two type of adenomatous polyps. One is a tubular, okay. One is the villus, and second is a mixed type, the tubovillus. For the tubular one, you can see all these glands here and the crypts. Okay, these are kind of very much tubular. Okay, these are the glands and these are the crypts and the deep layers. Okay, these are all circular, right? These are all the glands you can see. This is a tubular polyp. In case of villus polyp, you can see all these villi forming a structure within the polyp, right? This is the villus polyp. Okay, and the third one is a mix between the tuberous polyp and the villus polyp, right? Which is known as a tubovillus polyp. Okay, and the risk of malignancy will be increased with the size, because whenever you have a mutation, you will have a increase in the size of the polyp. That's why a polyp with more than 4 centimeter of size, it has a very high malignant potential, right? And whenever you have a villus adenoma, okay, it will secrete the mucin, and that can cause the mucinous diarrhea, a watery mucinous diarrhea would be present whenever the patient is having a villus adenoma. Okay, very important. And yeah, that would be all about adenomatous polyp. It is nothing but just a outgrowth of the GI wall, right? And it is because of the mutation in the APC gene. Only after the mutation in the APC gene you can have the adenomatous polyp, and this adenomatous polyp will be also known as the adenoma. Okay. Then comes the serrated polyp. Okay. For the serrated polyps, we have discussed already about the histology of the polyp, right? We're having very much serrations. Sawtooth pattern would be there. Okay, star-like appearance of the crypts would be there, or a very branching crypts could be there, right? And it happens because of the methylation in the CPG islands. And if you guys know that the CPG islands are present in the promoter sequence, right? So if a tumor suppressor gene is there, okay, and the methylation of the CPG islands occur, as a result, the tumor suppressor gene will become suppressed and the patient can have a cancer, right? And this defect generally occurs in the DNA mismatch repair gene. Okay, this defect occurs in the DNA mismatch repair gene that happens in the S phase mainly, if you guys remember from the biochemistry lectures about the DNA mismatch repair, right?
Yeah.
You can have a serrated polyps because of that. Okay, and that mutation can lead to the microsatellite instability mutation in the BRAF gene. You have a BRAF gene, okay, in which some microsatellite instability mutations occur, and that can lead to the serrated polyps. Okay, and when you do the biopsy of these polyps, they will be showing the the sawtooth pattern of the crypts on the biopsy, which we have discussed already, right? The star-like appearance or the very branching type of crypts you will see on the biopsy. And this is a very hallmark features of the serrated polyps. Okay, very much important. So yeah, that would be all about the serrated polyps. Any doubt on these two types, the neoplastic and the malignant polyps?
Can you repeat the process of CPG methylation?
See, you have a promoter for every gene, right? A promoter sequence for every gene, and the promoter sequence is rich in the CPG islands, right? If you remember from the biochemistry that the methylation will always occur on the cytosine, right? The C. And whenever the methylation occur, it will suppress the gene, right? So if a tumor suppressor gene is there, it has a CPG islands, and the methylation occur in the CPG island, then it will suppress the tumor suppressor gene. And if the tumor suppressor gene is gone, okay, then that can lead to the cancer, right? In the serrated polyps, okay, the silencing of the MMR gene occur, which is a DNA mismatch repair gene. Now, as a result, the DNA mismatch repair can never happen. This will lead to the accumulation of mutations within the DNA. And as a result, when the mutation occurs in the BRAF gene, it can cause the microsatellite instability path. It will cause some microsatellite instability, and that can cause the serrated polyps. Okay.
So we need two genes mutations like
You
MMR
need,
and for
yeah,
this two.
okay.
Okay, thanks.
First thing, you need to have the mutation in the MMR so that the DNA mismatch repair is inhibited. Okay, and if the mutation is happened in the BRAF, and because this mismatch repair is inhibited, then this mutation will be accumulated, and that can cause the serrated polyps. Okay.
Thank you.
So as you can see, the outgrowths. Okay, these are the polyps. Completely, these are the polyps. As you can see, as the outgrowth, they will be seeing on the endoscopy. Whenever you do the endoscopy, they will see as the outgrowth within the lumen of the colon, right? And then you need to do the histology of the patient. Okay, you will take the biopsy. You will observe it under the microscope, and what you will see is the histology, right? You will see the serrations. You can see the tubules. You can see the glands. You can see the villi, like, and based on the histology, you will differentiate the polyp with one of these things, right? Either it could be a normal architecture, okay? It could be a kind of abnormal architecture with the normal layers, okay? Either it could be a hyperplastic type with the serrations present, either it could be inflammatory type, either it could be either it could contain only the epithelial part with lots and lots of mucosal surface, right? Either it could contain the submucosa only, okay? Either it could contain the fat cells, which is lipoma, it could contain the smooth muscles, the leiomyoma, it could contain the fibrotic structures, the collagen deposition, that means the fibromas, right? It could contain many glands, which means the tubulous histology of the adenomatous polyp. It could contain the villi. Okay, it could contain the tubovillous histology, right? For a serrated polyps, you will have the serrations or the sawtooth-like patterns within the crypts that you can easily see. Okay. Now the polyposis syndromes, we have discussed about the PJ syndrome and the juvenile polyposis syndrome. Okay. Now for the adenomatous polyps, you need to know about the three syndromes. The first is the familial adenomatous polyposis. The second is the Gardner syndrome, and third is the Turcot syndrome. Okay, for the familial adenomatous polyposis, you will be having an autosomal dominant mutation in the APC tumor suppressor gene. Okay, you will be having a autosomal dominant mutation in that APC tumor suppressor gene, and whenever the APC gene is kind of inhibited, you will have a many outgrowths in the colon, right? So the patient will be having a thousands of polyps after the puberty because of this this APC gene mutation, right? And you will have a 5q22 hit. You will have a 5q22 two-hit hypothesis would be there. Okay, both of the genes must be knocked out. If you guys remember from the nuts and two-hit hypothesis, both of the genes must be knocked out before you can have a cancer or you can have any effect of the mutation, right? And it would be on the 5q22. Remember that. Okay, and these polyps, they always involve the rectum first, right? So you have to do the patient, you have to do the prophylactic, the colectomy in the patient, because there will be 100% chance of progression of these polyps into the colorectal carcinoma, because Once the APC mutation is occur, it can lead to the KRAS mutation. Then after the KRAS mutation, the P53 mutation can occur, and that can lead to the cancer, right? So you have to remove the colon completely to prevent this condition. Now, sometimes the familial adenomatous polyposis, it could also be seen along with the osteoma of the skull. Okay, so a patient having a familial adenomatous polyposis along with the osteoma of the skull, this is known as the Gardner syndrome. Okay, it will present as a bone pain, a facial pain would be there because it is an osteoma of the skull, of the facial bone, right? Mostly the mandible. Okay, so the patient will present you with a very severe type of bone pain, okay, which is not relieving with the NSAIDs or not relieving with the rest, right? Along with the familial adenomatous polyposis, that means it is a Gardner syndrome. And if you're having a familial adenomatous polyposis along with the malignant CNS tumor like the medulloblastoma or the glioma, okay, then it is known as the Turcot syndrome. Okay, and these patients, they have 100% risk of developing the colorectal carcinoma. Is that okay?
Yes.
So both for the sporadic cases as well as for the familial cases of adenomatous polyposis, you need to have the APC gene mutation first. Okay, then the KRAS mutation and then the P53 mutation, then you can have a colorectal carcinoma, right?
Yes.
So on this page, first we need to know what type of polyps are malignant, what type of polyps are benign, what would be the histology of that polyps, which are benign, which are malignant. Okay, then you will be able to differentiate between every of them, right? And then you need to know the associated syndromes with that polyp, right? The mutations are very important, and yeah, that'd be great. Okay, now we discuss the Lynch syndrome, okay, which is also known as the, someone remember the name? The HNPCC, right? Hereditary non-polyposis colorectal cancer. Okay, it is non-polyposis. See, no polyp will be present in case of colorectal carcinoma caused by the Lynch syndrome. Okay, it is without the polyps, a flat lesion will be there, and that flat lesion will be developed into the cancer, right? It is an autosomal dominant mutation in the mismatch repair genes. Okay, and the mismatch repair genes are the MLH1 and the MSH2. The MLH1 will code for a protein which is known as a MUT-L, okay, and the MSH2 will codes for a protein which is known as the MUT-S, and they will detect the mismatch pair, okay, and they will repair it then, okay, with the help of that sequence where they will call this what were the enzyme names, if anyone remember?
Glycosylase,
Yeah, the glycosylate enzymes, right? And the other one, endonucleases, yes. And finally the polymerase enzyme will come, and then the ligase enzyme will come to for the DNA repair, right? So if these enzymes will if these proteins become mutated, these genes become mutated, then you cannot detect the mismatch pair in the daughter strand, right? And as a result, this will be left untreated, right? And you can have a Lynch syndrome with that. Okay, you will have a microsatellite instability in it, okay, and you have a 80% of chances to progress it to the CRC. Very important, 80% chances are there for progression to the colorectal carcinoma, okay, and the proximal colon is always involved. This is an important thing. The proximal colon is always involved in it, okay, and you will have a classical triad of the
Pete, what is
endometrial.
instability, please?
See, in between the two genes, you have some sequence of the nucleotide, right? And a repeated sequence is there, and these are known as a microsatellites. A repeated sequence of the nucleotides will be there in between two genes, right? And these are known as a microsatellites. Whenever the number of these microsatellites increase or decrease, that can cause the problem, right?
All right.
These are the microsatellite instability. That's why the term instability If the number is increased too much or decreased too much, that can cause some kind of instability in it, and that can cause the cancer, right? So you will have a classical triad of the endometrial cancers, the ovarian cancers, okay, and the CRC. Okay, so if you encounter a patient having a family history of the endometrial cancer in one patient, okay, the ovarian cancer in other patient, okay, and the patient itself is having a CRC. That means you're talking about the Lynch syndrome, very important. So whenever you encounter a patient with a family history of colon cancer, ovarian cancer, and the endometrial cancer, that means the patient is having a mutation in the MLH1 and the MHZ2 genes. Okay, and please remember, all of these patients, they will develop the cancer before the age of 50. While the normal sporadic cancer of the colon, they happen after the age of 50, right? But in case of Lynch syndrome, the patient age must be less than 50 for the step one. You need to remember that. So whenever you encounter a patient having a cancer before the 50 years of age, that means it is a familial case. It is a case of hereditary mutations. Is that okay? Yeah. Okay. Now let's discuss about the colorectal carcinoma or the colorectal cancer. Okay. You will have the patient age which is more than 50 years. It's very important. Okay. The age must be more than 50 years, right? And they generally present you with the history of iron deficiency anemia. So whenever you encounter a patient having an age more than 50 years and they're having an iron deficiency anemia, the first thing that should come into your mind would be the colorectal carcinoma. You will always consider these patients having a CRC until proven otherwise. Okay, so whenever you encounter a patient having the iron deficiency anemia or the bleeding in the GI tract after the age of 50 years, okay, that means they're having the colorectal carcinoma, okay, unless you proven otherwise. Okay, and whenever a postmenopausal female also present you with the iron deficiency anemia, that means they are also having the colorectal carcinoma. Very important, right? Screening must be done after the age of 40. Oh, sorry, yeah, after the age of 50. Okay, and you will do the colonoscopy in the patient. For the colonoscopy, you will see the polyps in the patient. If the polyps are seen, that means the patient is having a CRC. Okay, you will need to remove that polyp, okay, in order to prevent the cancer to the patient, right? You can also do the sigmoidoscopy, okay, because you know that the most common location of the polyps are the sigmoid colon. So you will do the sigmoidoscopy. You can also do the fecal occult blood test, okay, in which in which you do the guaic positive testing. Okay, if the guaic positive testing is there, if that that means the patient is having a bleeding in the stools. Okay, and other thing you will do is the fecal immunochemical testing. Okay, and the DNA testing would be there. CT you can do. Okay, the CT, the colonography you can do. Okay, but the most important one is basically the colonoscopy. Okay, and the sensitive test includes the sorry, not sensitive one, but the test is basically the fecal occult blood test. So first you will do the fecal occult blood test to check for the blood in the stools. Okay, if that come out to be positive, then you will do the patient the colonoscopy. Okay, these are two important tests for the diagnosis or the screening of the colorectal carcinoma. Okay, whenever you encounter a patient with a first degree relative with a history of CRC, okay, that means it could be a case of hereditary cancer, right? Then you will begin the screening at the age of 40, before the age of 50. Okay, because there are highly chances of the Lynch syndrome, right? And because you know that the Lynch syndrome will always present you before the age of 50 years, then that means if you're having a patient with a family history of CRC in multiple members, okay, you need to do the colonoscopy before the age of 40. Okay, a patient with the inflammatory bowel disease, because you know that inflammatory bowel disease can progress to the cancer ultimately, you need to begin the screening, okay, at the before the age of 40 years, right? You can also give the patient you can also give the patient barium enema. Okay, and there you will see this apple core like structure where you have a cancer. Because of the cancer, it will be obstructing the lumen, right? So we'll have a loss of lumen there, and that's how you know that that's how you know that there must be some kind of a mass present. Okay, You can also look for the CEA tumor markers once you diagnose the condition, once you know that the patient is having a colorectal cancer, this cancer. You can also check for the CEA tumor marker, okay, and you do that for the monitoring of the recurrence and the treatment course, okay. Because once you know the patient is having a cancer and she or he is having elevated markers of the CEA, okay, then you will do the patient drug therapy. You will give the patient drug therapy or the chemotherapy, right? And then you will check for the CEA markers again, whether they are declined or whether they are still elevated, okay. And once the tumor is corrected, then you will again regularly check the CEA levels. If they become elevated against, that means the patient is having a recurrent cancer, okay. So they must not be used for the screening, because in other conditions also you can have a high CEA markers, right? You can only use them for the treatment monitoring and for the monitoring of the recurrence, okay. Any doubt so far about the screening?
No, thank you.
Thank you.
Please note the symptoms are mostly the iron deficiency anemia. Whenever you encounter a male or a female more than 50 years of age and they are having the iron deficiency anemia, okay, you will always consider them the colorectal carcinoma patients, okay. What is the epidemiology? Of course, the patients after 50 years of age and more than 25% of them can have a family history of the CRC also. The presentation, it depends on the location of the cancer, right? If the cancer is present in the rectosigmoid junction, which is the most common location, okay, and the second most common is the ascending colon and then the descending colon. Step 1 can ask you this. The most common location is the rectosigmoid colon, okay. The second one is the ascending colon and the third common is the descending colon, okay. If the cancer is on the right side, which is in the ascending or the descending colon,
Ascending.
in the ascending colon, see the lumen of the ascending colon is is very large, right? So the obstruction symptoms won't be there. First thing, what you can have is the occult bleeding as the major symptom, okay. So occult bleeding is the major symptom in case of a right-sided colon cancer or the ascending colon cancer, okay. So how does a patient present you with this? They'll present you with the dark stools, okay. Change in the color of the stools would be there, okay. And you can also perform the endoscopy in the patient to check for the polyps. You can do the GIT3 testing, okay. If the stools are quite positive, that means the bleeding it will be present in the stools, right? So that's how the occult bleeding will be tested, okay. And if the stools, and if the cancer is on the left side, which means in the rectosigmoid junction on the descending colon, then you need to know that obstructive symptoms are very much common, right? And the patient will present you with the constipation, abdominal distension, nausea, vomiting, okay, along with the hematochezia or the occult bleeding. So for the right side, the only symptom will be the occult bleeding. For the left side, okay, the symptoms will be the occult bleeding as well as the obstructive symptoms, okay. And that's why this ascending type can cause the iron deficiency anemia and weight loss, because just like any other cancer, you will have the weight loss, you will have the fatigue, right? For the descending colon, because of the mass, you will have the partial obstruction, the colicky pain and the hematochezia. Is that okay?
Yes.
And you will also have the change in the stool caliber. Very important. You will also have a change in the stool caliber. What does it means? These are your colon, okay. And let's suppose the mass is there, a polyp is there, right? As you can see, the lumen is very much reduced. So whenever a stool passes through this location, okay, the stool will become like this, right? While passing through this location, and as a result, the caliber of this stool is now changed, as you can see, okay. So because of this obstruction, the caliber of the stool is changed. The patient can tell you this, right? And yeah, that would be the symptoms of the descending type of cancer, right? If the polyp or the cancer is present in the descending colon, then the stool caliber symptoms would be there, the obstructive symptoms would be there, and the hematochezia would be there. Is that okay?
Yes.
And you guys also remember from the microbiology lectures that if you have a CRC, Okay, then you can also have a Streptococcus bovis induced endocarditis. Is that okay?
Yeah.
And you can also have an episode of diverticulitis, because with the tumor, you can have an increased interluminal pressure that can cause the diverticulum formation, and that can cause a diverticulitis also, right? What are the risk factors? Risk factors is the presence of any family history, which is the most important one. If you have a patient, with a family history of the CRC, that means there are very high chance that they can also develop the cancer. Okay. Second thing is the presence of any adenomatous or the serrated polyps on the endoscopy. Okay. Third thing would be the inflammatory bowel diseases. Okay, the tobacco use can cause it. Okay, and the diet, this is very important. Your diet is very important. Whenever the patient takes a diet which is low in the fibers and high in the fat and the red meat, the patient will be having an increased risk of developing the polyp and the colorectal carcinoma. Okay, very important. So a diet with a high meat and low fibers and high fat. Okay, these patients can have a high risk of developing the cancer. Is that okay up to here?
Yes.
Okay, so far about the colorectal carcinoma, we have discussed how you diagnose the condition. Okay, you have to do the screening first. In which age groups you will suspect the patient? Age more than 50. What symptoms could be present in these age groups? The most common one will be the iron deficiency anemia only. Okay, and the other signs of cancer like the weight loss, fatigue, this would be there, right? Anorexia could be there, malaise could be there, right? What are the presentations? It depends upon the location of the tumor. If it is in the ascending colon, okay, then the bleeding symptoms will be predominated. If the tumor is in the descending colon or in the sigmoid colon, then the obstructive symptoms would be predominated, right? What are the risk factors associated with that, right? Like the presence of any family history or the inflammatory bowel disease or any or any kind of adenoma in that, right? Any history of smoking, right? A diet which is low in fiber and high in the fat and red meat. They all are the risk factors. So whenever you encounter a patient more than 50 years of age with a history of iron deficiency anemia, you will always suspect the colorectal carcinoma in these patients. Is that okay up to here?
Yes. Yes.
Then you need to know about the pathogenesis of the colorectal cancer. Okay. So you need to know about the chromosomal instability pathway. First thing will be the mutation in the APC gene. And because of the APC gene, you can have a multiple polyps in the colon. Okay, multiple small size polyps within the colon, right? After the APC mutation, you will have the KRAS mutation. And this KRAS is basically a proto-oncogene. Okay. Whenever the KRAS is mutated, it can lead to the formation of adenoma, in which the size of the polyp is increased. Okay, if the size of polyp in case of the APC gene mutation was like 9 millimeter or maybe the 8 millimeter, okay, but the size of the polyp after the KRAS mutation, it will become 4 centimeter up to, right? Up to the 4 centimeter. So the size is increased, and now you call it the adenoma. It is still a benign lesion, right? Once the TP53 mutation and the DCC, remember that related in colorectal cancer, right? The DCC gene. If the mutations in both of these occur, that can lead to the formation of carcinoma. Okay, very important, and that's why the FA also said this line that if you have a polyp lesion which is more than 4 centimeter in the size, then a high chances are there that this polyp will become the carcinoma. Why? Because you know that only after the KRAS mutation you can have a adenoma of like a 4 centimeter up to, right? So because already two mutations are there, one mutation is needed. So a high chances of progressing it to the cancer. Is that okay?
Yes. Yes.
So what
And
is
yeah,
DCC?
it is again a gene, tumor suppressor gene related in colorectal carcinoma gene. It is known as DCC. Okay, and yeah, it has been shown that in this adenoma carcinoma sequence, there is an overproduction of the COX2. And because of this overproduction of the COX2 and the loss of APC gene, the hyperproliferation is there. Okay, so if you give the patient NSAIDs, they will inhibit the COX2, and as a result, they can inhibit the progression to the cancer. A very important thing. Okay, so as a treatment of this carcinoma, you also give the patients NSAIDs because they inhibit the COX2, and by inhibiting the COX2, you are inhibiting the hyperproliferation in case of APC gene mutation. Okay, so the first one is a chromosomal instability pathway, and the second pathway is the microsatellite instability pathway. Okay, in which you have a methylation of a mismatch repair gene, which is the MLH1 or the MSH2. Okay, you can have a Lynch syndrome, you can have a serrated polyp pathway. Okay, if you guys remember about the serrated polyps, we have discussed about the microsatellite instability pathway, we have discussed about the tumor suppressor gene, the mismatch repair gene, right? So two pathways are there. One is the chromosomal instability pathway, and second is the microsatellite instability pathway. With the chromosomal instability pathway, you can have a adenoma, then have a carcinoma. With the microsatellite instability pathway, you will have a serrated polyp, you will have a flat lesion, you will have a Lynch syndrome. So the age of patient is very important. In case of a microsatellite instability pathway, the age will be less than 50 years. In case of chromosomal instability pathway, the age will be more than 50 years. Okay, so age is very important. If the step one asks you, how does the patient is having the cancer, what pathway is involved, so you will look at the age of the patient, you will look at the family history, and then you can tell whether it is a chromosomal instability pathway or a microsatellite instability pathway. Is that okay?
Yeah.
Okay, so that's everything about the colorectal cancer. Okay, and if you read this under the headings, then you first need to know about the pathogenesis, then you will know about the symptoms based on the location, then the diagnosis, and then finally the treatment. Okay, study them like this. First, the pathogenesis. Okay, second is the second is the presentation of the patient. Okay, third is the diagnosis. Fourth is the complications could be or the risk factors, right? And fifth one is the treatment. Read this cancer under these headings. You will be very easily remember all of the symptoms and all of the things which are associated with this colorectal cancer. Okay, so any doubt up to here?
No, thank you.
Okay, so now we need to study about the cirrhosis and the portal hypertension. See, cirrhosis is nothing but the fibrosis within the liver, right? And you guys already know that the hepatic cells of Ito, remember, or the interstitial cells, they normally when they're inhibited, when they're quiescent, okay, they will be storing the vitamin A. But once they become activated, they will be converted into the myofibroblast and they will be start secreting the collagen. The fibrosis will happen, right? So the stellate cells or the interstitial cells of I2, these are responsible for the cirrhosis, which is basically the fibrosis or diffuse fibrosis within the liver. Okay, it will present you as the regenerative nodules. Okay, as you can see, this is a nodular appearance you will see within the liver. And whenever you see these nodules like structures with a loss of normal architecture, you will see the patient is having a cirrhosis. Okay, and because of the cirrhosis, the normal architecture is lost, the normal blood supply is being compromised, the patient can have a portal hypertension, the patient can have a block in the venous drainage from the portal veins, right? The patient can have a splenomegaly because of the splenic congestion. Okay, the patient can also have a hepatomegaly, right? The patient can have a portal hypertension, which we discuss symptoms soon, right? So what are the etiologies? It includes the alcohol. Okay, it includes a non-alcoholic steatohepatosis. It includes a viral hepatitis. It includes the autoimmune hepatitis. It includes any biliary disease or any metabolic disorders. And does anyone remember the metabolic disorders which can cause a cirrhosis?
Hereditary fructose intolerance
Yes.
and
And the second one?
Galliput deficiency.
Yes. Okay, remember this. So metabolic diseases, biliary diseases, autoimmune, viral, non-alcoholic, and alcoholic hepatosteatosis. Okay, they all can cause the cirrhosis. And cirrhosis is basically the last damage of the liver. Okay, it would be the end stage hepatic disease. After that, your liver is completely failed. Okay, there is no way the liver can go back to its normal type. Okay, and the only thing you can do is to remove the liver and to do a transplant, right? Otherwise, what's going to happen if the etiologies are continued? then the patient can also develop the hepatocellular cancer. Very important, cirrhosis is a very important cause of the hepatocellular carcinoma. Okay, so first you need to know about what is cirrhosis. It is basically nothing but just a diffuse fibrosis and the formation of regenerative nodules, which you can see here. These are the nodules. You need to know about the risk factors, and then you need to know about the complications. Okay. Let's discuss the portal hypertension. Okay. Now, because of the portal hypertension, you're having an increase in the pressure in the portal venous systems, right? And because of this increase in the portal venous system pressure, you can have multiple symptoms. Because of an increase in pressure, you will have a third spacing, which means the fluid will be coming out of the veins and accumulating in the interstitial space. That can cause the ascites, that can cause the edema, right? That will activate the RAS system further because of hypovolemia. And why hypovolemia is occurring?
Loss of fluid into the interstitial space.
Yeah, because all the fluid will be accumulating in the interstitial space, the circulatory blood volume will be lost. And whenever the circulatory blood volume is lost, that can activate the RAS system. You will have a you will have a reabsorption of the sodium and the water that will further to causes more edema, right? You will have the vasodilation, right? The bacteria overgrowth will be happen, and these bacteria will release the nitric oxide. The nitric oxide will further dilate the vessels, and they will cause further accumulation of the blood, further leakage happen, and it will promote more ascites, right? So a kind of positive feedback loop is there, right? Ascites that will lead to a loss of volume lead to activation of RAS. More RAS means more ascites means more RAS. Okay, so this is how the ascites happens in the portal hypertension. So what are the causes? Causes first include the cirrhosis, of course, we have discussed that. Second is the vascular obstruction, like in case of portal vein thrombosis. If you have a blockage in the portal vein before the liver, then the liver will be absolutely normal. But you are having a portal hypertension, you will be having a edema, everything would be there. You will have a splenic congestion, right? You will have the splenomegaly, everything would be there, but the liver will be absolutely normal, right? In case of Budd-Chiari syndrome, you are having a thrombosis in the hepatic vein, right? And now the liver is also compromised. You will have the hepatic congestion, you will have the splenic congestion, hepatosplenomegaly will be present, and all of the symptoms of the portal hypertension. Cystosomiasis is a very important cause of the portal hypertension. Heart failure can also cause the portal hypertension. Because of the heart failure, you will be having a loss of pump, and as a result, all of the blood will be start backflowing. Okay, start accumulating within the venous system. Okay, that includes the hepatic vein, the portal vein, and other veins. You know, the congestion, you will have the portal hypertension. So these are all the causes of the portal hypertension, right? In the portal hypertension, you're having an increase in the venous pressure. Now the complication, we will study about that later, right? Is that okay up to here? The cause of cirrhosis and the cause of portal hypertension?
I have one question.
Yes.
Is there any reason behind portal vein thrombosis? Like, is there any disease which can cause portal vein thrombosis?
Just like a deep vein thrombosis, you can have a portal vein thrombosis also. Like in case of cancer, you will be having a this state, the coagulable state, right?
Yeah.
And because of the cancer, you can have a thrombosis.
Okay.
Because of stasis, you can have a thrombosis.
Right. And I have one doubt. Do we get any kind of thrombosis in paroxysmal nocturnal hemoglobinuria also?
Yeah, of course, you will have a Budd-Chiari syndrome in that.
Okay. Got it. Thank you.
Okay, so yeah. So that's about the cirrhosis, which is a fibrosis, the portal hypertension, which is increase in the pressure in the portal vein, right? We have discussed their causes: alcohol, non-alcohol, chronic, viral, autoimmune, biliary disease, genetic abnormalities. For the portal hypertension, we have discussed about the cirrhosis, okay, the vascular obstruction, like the Budd-Chiari syndrome or the portal vein thrombosis or the cystosomiasis or the heart failure. Now, what happened when the liver is failed? Okay, when you get the cirrhosis, okay, what things gonna happen? The first thing would be the loss of all the metabolism in the liver, right? And because of this loss of metabolism, you will having a, just give me a second. Yeah, yeah. So first thing would be the loss of metabolism of different substances. right? The first one is the estrogen. Okay, estrogen will be metabolized by the liver. Okay, if the liver is not working, then the estrogen levels will become very high, right? Because of that, the patient can have a gynecomastia, right? The patient can have a testicular atrophy, right? The patient can also have the amenorrhea because of that, right? The patient can have a spider angiomas and the palmar erythema, very important. So spider angioma, the palmar erythema, right? Testicular atrophy, gynecomastia, and the amenorrhea. All of these are because of high estrogen level, because you know that the liver is responsible for the degradation or the metabolism of the estrogen. That thing is not happening, you will be having a very high estrogen level. Second thing is the ammonia. You guys know that the ammonia will be metabolized in the liver, okay, and then it will be converted into the urea. Okay, it will reach to the kidney and it will be excreted. If the liver is not functioning, then the ammonia levels will become very elevated and you will have a hyperammonia. And you guys already know from the biochemistry lectures, whenever you have a hyperammonia, you will have the neurological symptoms like the flapping tremors, or no, also known as the asterexis, right? And the other symptoms will be the cerebral edema would be there, right? Why cerebral edema would be there?
Glutamine attracts water.
Yes, exactly. Because of the glutamine, and glutamine is not a neurotransmitter. The glutamate is a neurotransmitter, but glutamine is just a osmotically active substance that can cause the edema within the brain. It will inhibit your Krebs cycle, that can lead to the cell death also, right? Your inhibited neurotransmitters will be lost, like the GABA and the glycine, and that can further promote the excitotoxicity, right? So these things are happening because of a loss of ammonia. Sorry, because of high ammonia levels, right? Because of the bilirubin disruption, because you know that that liver is also involved in the bilirubin formation and its metabolism, right? So we'll be having a very high level of bilirubins, right? The unconjugated bilirubin will become very high, okay, because this unconjugated one will not be converted into the conjugated bilirubin. So the patient will be having a very high a very high unconjugated bilirubin. Jaundice would be there, right? Which is a yellowish discoloration of the skin and the yellowish discoloration of the eyes also, right? And you also know that the liver is also involved in the formation of clotting factors, right? If the liver is become dysfunctional, the clotting factors won't be formed. And as a result, what you will get is the purpura. Okay, you will get the poor wound healing. You will get the ecchymosis because of that. Okay, you will get the bleeding complications like the hamartosis, right? Like the organ bleeding could be there, right? And you will also have the hyponatremia. Why the hyponatremia is happening?
Hepatorenal syndrome.
Because of the hypervolume, because of and what is the hepatorenal syndrome?
I don't understand that actually at all.
See, it's nothing but because of the hypovolemia, you are having an activation of RAS, right? And
Like-
this RAS will cause the accumulation of sodium and water, more water, and and you're also having an activation of ADH, right? And that can lead to the hypervolemic hyponatremia, and this is known as the hepatorenal syndrome, right?
Okay. Yeah.
So you will be having a hyponatremia, and please remember, it is not a normal one. It is because of the hypervolemia. So we'll be having a hypervolemic hyponatremia, right? And yeah, for the cardiovascular, you can have a cardiomyopathies because of high volume overload in the heart. Okay, you can have the chronic heart failure also. You will have the peripheral edema.
Why
Right.
hyperbilirubinemia?
Because the liver is also involved in the metabolism of bilirubin.
Okay.
Yeah, the unconjugated one will convert into conjugated bilirubin. Then the conjugated one will be
Yes.
excreted, right? So this thing will be inhibited. You will be having a hyperbilirubinemia, right? So these are all the complications because of the liver dysfunction. Some complications because the liver is not metabolizing the toxins like the ammonia. Okay, it is not metabolizing the substrates like the estrogen. Some complications because liver is not forming proteins. Okay, like the albumin won't be there. You will get the edema throughout the body, right? And the formation of clotting factors will be inhibited, and other proteins also, right? You will get the complications because of that, right? So these are the complications because of a liver dysfunction. Now, because you're having a cirrhosis, you will also have the portal hypertension, right? And because of the portal hypertension, you will also have the edema. Okay, and the first thing because of portal hypertension is your ascites. Ascites is nothing but the accumulation of fluid in the interstitium of the abdomen, right? And this is known as the third spacing. Third spacing is nothing but the presence of fluid in the abnormal locations where the fluid shouldn't be present, right? This is known as the third spacing, and that can lead to the ascites. See what happens whenever you get the portal hypertension, you will be start having the high pressure in the portal vein, right? And because of this high pressure, you will be having a leakage because of this high hydrostatic pressure. Okay, you will be having a leakage of all of this fluid from the blood vessels from the veins to the interstitium, right? This is the first thing. Second thing, because of this portal hypertension, because of kind of a blockage, you will be having a bacterial overgrowth also, right? And because of the bacterial overgrowth, okay, these bacteria will release a nitric oxide, very important. And because of the release of this nitric oxide, it will promote further vasodilation of the veins, further venodilation. And because of the venodilation, more pooling of the blood will occur, right? And because of the pooling, further more leakage of the blood will occur, right? And because of this leakage of the fluid, you will be having a low volume in the circulatory system, right? And as a result, the RAS system will get activated. Okay, and the ADH will also get activated because hypovolemia is a important stimulating factor for the ADH secretion. So you will get the high ADH level, you will get the high RAS levels, right? They will further promote the free water absorption, the sodium absorption. That can lead to the hypervolemic hyponatremia. Okay, and they will also promote the vasodilation again, right? They will, and because of the vasodilation, they will further promote the leakage of the fluid from the veins to the interstitium. That will further more promote the ascites, right? So in ascites, if I say a summary, you will be having a vasodilation, you will be having a high pressure, you will be having a high levels of nitric oxide, you will be having a high RAS system, you will be having a hypervolemic hyponatremia. Is that okay about ascites?
Yes, it is.
Okay. Now, second thing, because of the portal hypertension, you will be having some areas, the anastomotic areas will be there in the body, like in the paraumbilical region, like in the anal region, and like in the esophagus. Okay, because of this anastomosis in the esophagus between the esophageal vessels and the left gastric arteries, you will be having a esophageal varices. Okay, which can cause the life-threatening hematemesis, right?
Yeah.
Because of the anastomotic, because of the anastomosis between the paraumbilical veins and the epigastric veins, inferior epigastric veins, you can have the caput medusae, as you can see here, right? Because of the anastomosis between the superior rectal artery and the middle and inferior rectal artery, okay, you can also have the anorectal varices that can cause the bleeding with the stools, as well as the pain, like the hemorrhoids, right?
Yeah.
Is that okay? So these complications are because of the portal hypertension, right? And the previous one we have discussed is because of the cirrhosis or the liver dysfunction, right?
Yes.
So we have discussed about the jaundice, the spider angiomas, the palmar erythema. Please remember it is because of high estrogen levels. Purpura because of loss of the platelet function, right? The petechial rash would be there because of loss of the clotting factors. Esophageal varices because of the portal hypertension. Gastric varices would be there because of the portal hypertension again. Caput medusae because of the portal hypertension can occur. Ascites because of the portal hypertension can occur. Anorectal varices because of the portal hypertension can occur, right? The reproductive anomalies because of high estrogen levels, because of loss of metabolism of the estrogen, right? Neurological dysfunction can occur because of hyperammonia, the hepatic encephalopathy, and the astraxis can happen. For the GI, you will be having the anorexia, nausea, vomiting, abdominal pain. Because of the liver dysfunction, you will be having a right upper quadrant pain because that's the location of the liver. Okay, you will be having a nausea, vomiting, the GI symptoms. Okay, you will also have the sweet fluctuant breath, very important. You will have the hematologic problems like the thrombocytopenia because the liver is also responsible for the for this megakaryocyte things, right? Anemia would be there, right? The coagulation disorders would be there because of loss of the clotting factors, right? Splenomegaly would be there because of the congestion, because of portal hypertension. You will be having a splenic congestion, right? For the renal, you will be having a hepatorenal syndrome, which is nothing but just the activation of RAS because of hypovolemia. Okay, you will be having a renal dysfunction also. You will be having a very high creatinine levels along with high GRAS and ADH levels. Okay, you will be having a high levels of bilirubin. You will be having a low levels of sodium. You can also have the high output cardiac failure. Okay, because of this branching vasodilation, and the AV shunts can also create it. You can also have a peripheral edema because of albumin first, because of portal hypertension, second because of cardiovascular compromise. Is that okay about the about this diagram completely?
Yeah.
I have something to ask.
Yes.
Um, we get portal hypertension because of either abnormality in liver or in portal vein or in
Yes.
hepatic vein, right?
Yes.
Okay.
Yes.
If the abnormality is in the liver or hepatic vein
Yeah.
or portal vein, we get ascites. And but
Yes.
in the abnormality is present in the portal vein, hepatic vein, we don't get ascites, right?
No, we get the ascites. Why don't we get the ascites in
We get
case of Budd-Chiari syndrome?
uh,
If we have a
you
blockage
mean
of the
to
venous pathway, if you're having a blockage in the venous pathway, then every blood which is before the blockage, it will be start accumulating there, right? It will cause an increase in pressure before the obstruction, and that even includes the portal vein in case of hepatic vein thrombosis, right?
no, portal vein or hepatic vein? Are you saying portal vein or hepatic vein?
In both.
In Budd-Chiari, we get thrombosis in hepatic vein mostly.
Yes. Yes.
So actually, I'm a bit confused. I got a question in your word,
Yes.
in which it was like they classified it portal hypertension as pre-sinusoidal and
Yes.
sinusoidal. In
Yes.
pre-sinusoidal, like as in case of portal vein thrombosis,
Yes.
they mentioned that we don't get ascites.
No, we get the ascites. You can send me the question. There might be some confusing, I think. There might be some confusion. You can
Okay,
send me
I'll
the
send
question.
you.
We will discuss that. Yes. Don't worry about
Okay,
that.
okay.
But you will get the. But in case of Budd-Chiari syndrome, even in case of portal vein thrombosis, you can get the portal hypertension. As you can see, that portal hypertension, it is listed in the first aid also. As you can see, the portal hypertension, the risk factors are the Budd-Chiari syndrome and the portal vein thrombosis, right?
No, I'm actually confused about hepatic vein thrombosis, not the portal vein thrombosis.
Yeah, the Budd-Chiari syndrome is because of the hepatic vein thrombosis, right?
Yeah.
It is listed in the first aid. If you get the Budd-Chiari syndrome, if you get the hepatic vein thrombosis, then you can have a portal hypertension.
Yeah. Yeah, we get the portal hypertension, but I'm confused about the ascites thing. Like
Ascites is because of
we
the
don't
portal
get.
hypertension. Ascites is because of the portal hypertension only.
Okay.
As you can see, FA is listed under the heading of portal
Okay.
hypertension also.
Okay,
See?
I'll send you the question.
Yeah, you can send me the question. We will discuss that.
Yeah.
It might depend
Yeah.
upon the stage also. It might depend upon the stage
Yeah.
also. If you
Okay.
get a Budd-Chiari syndrome, then in the initial stage, everything would be normal, right? In the later stage only, you will get the ascites. But in case of a portal vein thrombosis, at a very early stage, you will develop the ascites. It might be saying like that something. Yeah.
Okay. Okay.
Just send me the question.
Yeah.
We'll
Yeah.
discuss
Okay.
that. Okay.
Okay. Okay.
So, any more doubt on this page?
No, thank you.
So, how will you manage the acute portal hypertension? How will you manage that?
Beta blockers.
Not beta blockers this time. You need to inhibit the vasodilation of the splanchnic circulation, right? Splanchnic vessels. You need to inhibit their vasodilations, right? But the most important that you can do is the TIPS. If you remember, in case of portal hypertension, if the blockage is within the vein or in the or in the liver, then you can do the TIPS, right? But if the patient is having, if the patient is having this hyperammonia also, okay, along with the portal hypertension, if the patient is also having a hyperammonia, then you cannot perform the TIPS. Does anyone know why?
Yeah, because the liver is getting bypassed and no ammonia is getting metabolized anymore.
Yeah, exactly. Exactly. So if you get the hyperammonia along with the portal hypertension, please note you cannot do the TIPS. Only in case, only in the uncomplicated case of the portal hypertension, you can do the TIPS. Right? Now, let's talk about the drug therapies. You will give the patient somatostatins or the octreotide, because you guys know that these agents will actually inhibit the release of glucagon and the vasoactive peptide, right? And as a result, what's going to happen? Glucagon is actually working through the cyclic AMP that can cause the vasodilation, if you guys remember. And the VIP is working through the nitric oxide that can cause a vasodilation, right? So you need to inhibit these agents so that you can have a vasoconstriction, right? Somatostatins or the octreotide are very useful for the acute management of portal hypertension if TIPS is not available. Is that okay?
Yes.
So that's about the treatment for the portal hypertension, right? And the furosemide therapy could also be used for the ascites, okay? Because anywhere inside the body, if you're having an edema, okay, if you're having an acute edema anywhere in the body, then first thing you will give the patient is a furosemide, right? Which is the loop diuretics, and they are very potent diuretics, so they will decrease the body volume, right? So the furosemide can also be given for the ascites, and the other things you can do is the somatostatins or the octreotides, or you can do the TIPS if the hyperammonia is not there. Is that okay up to here?
Yeah.
Okay. Okay, so now let's discuss the spontaneous bacterial peritonitis. As the name suggests, it will be a peritonitis, which means the inflammation of the peritoneum. And you guys know that whenever an inflammation of the peritoneum is there, the patient will always present you with
Guarding and
rebound tenderness. Yes. Okay. Now, so what happening in this case that the patient, those patients who are having a history of cirrhosis or the ascites, okay, whenever you admit them in the hospital, okay, then their case could be complicated by the bacterial overgrowth, which is mostly by the gram-negative organisms like the E. coli and the Klebsiella, and less commonly the gram-positive bacteria like the Streptococcus. Okay, so it is a superficial infection, okay, or I can say a super infection with these bacteria in a patients with the cirrhosis or the ascites. Okay, the ascitic fluid which is present in the abdomen, okay, this fluid will become infected, because I told you in case of portal hypertension, you will be having a bacterial overgrowth, remember, which will be releasing the nitric oxide. Yes.
yes.
If that fluid is become infected with these bacteria, then you can have a spontaneous bacterial peritonitis. Mostly it is asymptomatic, but the patient can present you with the fever, chills, nausea, vomiting. Of course, the ascites would be there, abdominal pain with the with the guarding and the rebound tenderness. Okay, the shock can also happen to the patient. Okay, septic shock would be there, right? And the patient must be having a history of cirrhosis, and the patient must be a hospitalized patient. It is a very important thing. It is a hospital acquired infection. Okay, a hospital acquired infection of the ascitic fluid, I must say, right? And yeah, and how would you do the diagnosis? You will draw the fluid, the ascitic fluid, and then you will check for the neutrophil count. If the neutrophil counts are more than 250 cells per cube, that means the patient is having a spontaneous bacterial peritonitis. And the treatment includes the antibiotics like the third generation cephalosporins, the cefotaxime or the ceftriaxone. Okay.
Yeah.
So that's everything about the this spontaneous bacterial peritonitis. Just give me a second. Yeah, so that would be everything about it. You will get a patient with a history of cirrhosis, with a history of ascites. Now the patient is hospitalized, and in the hospital, the patient developed the infection of the ascitic fluid. Okay, this infection will reach the peritoneum, and the patient will be having symptoms like fever, chill, nausea, vomiting, rebound tenderness, guarding, and the shock. Right? For the diagnosis, you will draw the fluid from the ascites, and you will check for the neutrophil count. If it is raised, that means the patient is having acute inflammation. You will give the patient ceftriaxone. That's everything about it. Then let's discuss about the serum markers of the liver. Okay, first markers are those which are released because of the damage of the hepatocyte, because you know that hepatocyte contain many enzymes like any other cell. Okay, whenever the hepatocyte become damaged, their cell membrane get damaged, these enzymes will be leaked out, right? And as a result, you can detect these enzymes easily in the blood. Increased level of these enzymes will be detected, right? The first enzyme is the aspartate aminotransferase, or the AST. Remember the reaction for the aspartate aminotransferase?
Yes, aspartate gets converted into oxaloacetic acid.
Within the mitochondria, right?
Yeah.
Okay, so this reaction is conducted by the aspartate aminotransferase. Whenever the cell get damaged, this enzyme will be released. Second is the alanine aminotransferase, which converts the alanine into the pyruvate, right? And if the cell get damaged, this enzyme will also be released, right? In case of a normal destruction of the liver, you will have the high ALT count than the AST count. But in case of a alcoholic damage to the liver, you will have the high AST count than the ALT count. It is very important. So whenever you encounter a patient having a high AST than the ALT, that means the patient is having an alcoholic liver injury, right? And whenever the ALT is more than AST, that means it's a non-alcoholic liver injury. And please note, even in the alcoholic hepatitis, the AST level will never cross 500. If the levels are more than 500, then it is not an alcoholic liver injury. It is something else like the viral hepatitis, or might be the autoimmune one, but not the alcoholic. Okay. And yeah, aminotransferase level more than 1000. Okay. They will suggest any ischemia. Okay. They will suggest any viral hepatitis, and they will suggest any autoimmune hepatitis, not the alcoholic hepatitis. Very important, right? Third enzyme is the alkaline phosphatase. Okay, alkaline phosphatase is released by another tissue also, if anyone remember.
Bone.
Bones. So why the bones need alkaline phosphate?
To have an alkaline environment to build up bone.
Yeah, exactly. So in case of any bone disorder, you can have a high alkaline phosphate. In case of any liver disorder, you can have an alkaline phosphate. Okay, so alkaline phosphate is kind of a sensitive marker, but not as specific for the liver, right? And yeah, so okay, so it is kind of a sensitive but not as specific. Third one, and the last one is the gamma glutamyl transpeptidase, or the GGT. Okay, it is only increased in the liver associated pathologies, right? It is only increased in the liver associated pathologies, but not in the bone associated. So whenever you encounter a patient having a high alkaline phosphate, then you always need to check for the GGT levels to ensure that the patient is not having a liver pathology, but the bone or any other pathology, right? It is very important. Step one will ask you this. If you encounter the patient with a high level of ALP, what is the next step you will do? You will test the patient for the GGT levels. Okay. And the GGT levels will help you ruling out the liver pathologies or the bone pathology. Is that okay?
Yes, yes.
These are the enzymes which are released because of the cell damage. These are the markers will get elevated. Now the markers of the liver function. And these markers will tell you how much damage is occurring. The markers we have studied earlier, they will just tell you that the liver is being damaged. They won't tell you how much damage is there, how much, how much the progression of disease is there. But the markers, the functional markers, they will tell you how much the liver dysfunction is there. The first marker is the bilirubin. Okay, you will have the high bilirubin level in various liver diseases, like the biliary obstruction, like the hepatitis, like the cirrhosis, like the hemolysis, right? The most important ones are the albumin and the prothrombin time. Okay, whenever you have a liver dysfunction, you guys know that the albumin is being produced by the liver. Okay, so whenever you have a liver dysfunction, you will always lose the albumin, right? And second thing is the prothrombin time, because the liver is also involved in the generation of various clotting factors like a 2, 7, 9, 10, protein C, protein S also, right? In case of a liver dysfunction, these clotting factors are lost, and now you will get a very high PT level. Now note one thing, that the albumin has I think a half-life of 1 month, right? 21 days, right?
Yeah.
So whenever you have an acute liver damage, acute severe type of liver damage, it won't affect the albumin levels, right? Albumin levels would be normal up to 21 days, right? But this prothrombin time, because after kind of I think 7 or 8 hours later, okay, the clotting factors will be inhibited and the prothrombin time will be start rising. So for any acute injury, okay, you will always look for the prothrombin time to check the progression of disease, okay, or the type of damage or how much damage is there, right? In case of only a chronic damage, okay, after 21 days you can check for the albumin levels. So if the step one will ask you, and they will give you a patient with a history of cirrhosis or something like that, and the history is less than 21 days, okay, and they will ask you what marker would you use for the liver dysfunction. So this would be the prothrombin time, not the albumin, because albumin will always be normal up to 21 days. If they give you a patient with a history of this cirrhosis more than 21 days, then only you can check the albumin levels to check for the liver damage. Is that okay?
Yes.
The other factor is basically the platelets. Whenever you have a liver dysfunction, you will have a low thrombopoietin, right? And that can lead to uh, the loss of platelets, right? They can cause an increase in the bleeding time, right? And so yeah, this marker can also be used, but it is not a very specific marker. It is a kind of sensitive, but not as specific to the liver. Again, because of the toxin increase in the body, you can also have uh, the platelet dysfunction, right? So because of toxin accumulation in the body and because of the low thrombopoietin level, you can have the high bleeding time. So bleeding time is not a kind of diagnostic for the liver injury only, okay? So we do not use the platelets or the bleeding time as the marker for the liver damage, although it can be used, but it is not specific. It is only the sensitive. Because of the liver damage, you are having two things. One is the loss of thrombopoietin and second is the accumulation of toxins, and both of these things will contribute to the platelet dysfunction, right? Both of these things will elevate the bleeding time. So measuring the bleeding time won't give you an exact estimate of how much damage has been occurred to the liver, right?
Yeah. Yeah.
So know these markers. The markers, whenever a cell get damaged, they will tell you that the damage is being occurred, but they won't tell you how much damage is there. To check that, you need to measure the level of bilirubin, the level of albumin, the level of prothrombin, and the level of platelets. Platelets are not much used. Okay, the prothrombin for the acute damage and the albumin for the chronic damage would be used. Any doubts so far about the serum markers?
No, thank you.
Okay, so we will take a short break and then we will discuss about the Rice syndrome and the other liver disorders. Okay.
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 Okay, so we have discussed the liver markers, okay, in which liver markers will show you that the liver is being damaged and which liver markers show you how much damage has been occurred, right? And now let's discuss the Rice syndrome. Okay, Rice syndrome is basically the fatal childhood hepatic encephalopathy. Okay, it happens whenever you give a child, whenever you give a child the aspirins. Okay, so what happens that this aspirin actually has a metabolites that inhibit the beta oxidation in the liver, and once the beta oxidation is inhibited, what's gonna happen? All of the fat which is coming in the liver from the peripheral tissues, it is started accumulating inside the liver. Is that okay?
Could you please repeat?
See, whenever you give the aspirin to a child, okay, a child less than 14 years of age, okay, in that case, what's gonna happen? the beta oxidation is inhibited because the aspirin metabolites are beta oxidation inhibitors. Okay.
Okay.
And now because of beta oxidation inhibited, every fat which is coming to your liver for the metabolism, okay, for the conversion into the ketones or other things, right, they will be start accumulating within the liver, right?
Yeah.
And as a result, what you get is the hepatic steatosis, right? So this is what you see. The hepatic steatosis is what you see whenever you do the biopsy of a patient with the Rice syndrome. Is that okay up to here?
Yes, perfect.
Okay, now because of this hepatic steatosis, you will having a hepatic dysfunction. And because of the hepatic dysfunction, the ammonia will be start accumulating in the blood. The patient will get the hyperammonia. Because of the hyperammonia, the patient will also get the hepatic encephalopathy, right? And
Yes.
all of the glutamate, all of the GABA, okay, this will be converting into the glutamine, right? And this will cause a cerebral edema. Astraxis would be there, hepatic encephalopathy would be there, right? And what you will find is the fatty liver. Why fatty liver? Because of the inhibition of beta oxidation. Okay, the gluconeogenesis would be inhibited. What you will get is the hypoglycemia, because the GI symptoms would be there. Okay, the abdominal pain would be there, vomiting would be there, hepatomegaly would be there. The patient can get the coma. Is that okay?
Yeah.
So Rice syndrome generally occurs whenever you give a patient less than 40 years old aspirin. This aspirin will inhibit the beta oxidation, and because of the beta oxidation inhibition, you will get the hepatosteatosis, the fatty liver. Microvascular fatty changes will be there. Liver function will be compromised. You will get the hyperammonia, you will get the hypoglycemia, you will get the hepatic encephalopathy, hepatomegaly, vomiting, whatever things, right? This is the Rice syndrome. Any doubt in it?
No, thank you.
And what markers you will get? A high ALT count, a high AST count, and ALT count is more than the AST, right? You can also have a low, you can also have a high PT count, right? Albumin levels, it would be normal in the Rice syndrome because it would take 21 days to decrease the albumin levels, right? So albumin would be absolutely normal. If the step one asks you how you will assess the liver dysfunction, how much dysfunction is being occurred, then you will check the patient PT levels. Okay, very important. So yeah, that would be about the Rice syndrome. And please remember, whenever you get a high alkaline phosphate, you always need to check the patient for the GGT to make sure that the liver pathology is there or not there. Let's discuss the alcoholic liver disease. If you guys remember from the general pathology, we have discussed that the hepatosteatosis or the accumulation of fat in that cell, it is a kind of reversible injury. Remember?
Yes.
Okay, so the keep this in the mind. In case of a alcoholic liver disease, we have discussed how the alcohol can cause the fat accumulation. Remember, because all of the NADPH and all of the NAD, it is being utilized for the NADP, and all of the NADPH being utilized for the NADPH. Sorry, NAD, right? So ultimately, your body's NAD stores, okay, and the NADPH stores, they are being depleted, right? Is that okay up to here?
Yes.
And because of the depletion, you need the NADH2 for the continuation of the you need the NAD to be converted into the NADH2 for the glycolysis, for the TCA, and for many other cycles, right? Now, because you have a high NADH2 level and a very low NAD level, reactions will be start reversing. Okay, they will be start forming the NAD from the NADH, right? And as a result, you will get the more fat synthesis, you will get the more ketone synthesis, you will get the more lactic acid synthesis. Okay, there will be a reversal of the TCA cycle, right? You will be having the formation of oxaloacetic acid, okay, and all these things. So that will lead to the hepatic steatosis. Is that okay?
Yeah.
And this hepatic steatosis is a reversible type of injury. It is all reversible. Even if you stop the alcohol at that time, okay, all of the symptoms will be reversed. Okay, what you will see in the hepatocytes, because of the fat accumulation, you will see the fatty changes. All of these cells you are seeing, these clear cells, these are the fat within the cell, right? The H&E stain cannot stain the fat, and they will be seen as very much clear areas, right? This is the hepatic steatosis. Okay, what you can do is the Sudan black staining. If you guys remember from the from this malabsorption syndromes, we have discussed a Sudan staining. Remember?
Yes, heart.
Sudan staining for the fat stainings. Okay, so you can do the Sudan staining, you can do the HND staining, that will be for the fats. Because of high NADH levels, you will be having a inhibition of beta oxidation, you will be having a high triglyceride production that can lead to the hepatic steatosis. Now, if you continue to drink the alcohol, then it can lead to the inflammation of the hepatocytes, right? And that can lead to the alcoholic hepatitis. Okay, it is a necrotic type of it is a necrotic type of inflammation. The necrosis of the hepatocytes will occur. Okay, and because the necrosis is there, there's always the neutrophilic infiltration there, right? You will get the intracytoplasmic inclusions of the damaged keratin of the cell. Okay, and these are seen as the Mallory bodies. As you can see, these are the this is the cytoplasm. Within the cytoplasm, you will see some pinkish or the eosinophilic structures or the eosinophilic inclusions. These are known as the Mallory bodies, highly specific for the alcoholic hepatitis. Okay, the Mallory bodies. Please remember that. They will ask you, and first thing they will what they can do, they can give you a histology of the patient liver of the alcoholic hepatitis. Okay, and they will mark an arrow for some structure. They will ask you what structure is this, or they can further move one step and they can ask you about the Mallory bodies, that what in reality these bodies are, right? So these are the damaged keratin filaments, and please remember they are intracytoplasmic. They are intracytoplasmic, very important. Okay, now if you further continue to drink the alcohol, even at that stage, even at the alcoholic hepatitis stage, okay, the injury is kind of reversible. You have the cells, you have the stem cells that can still regenerate the liver completely. But if you continue to drink alcohol even after this stage, then the irreversible damage occur. The stem cells will be died, okay, and the liver architecture will be completely destroyed, right? You have the stellate cells or the ito cells, they will get activated, they will start doing the fibrosis. Okay, you will get the sclerosis around the central vein also. You will get the formation of regenerating nodules. Very important, you will get the formation of regenerating nodules which are surrounded by the fibrous bands. Okay, these are the fibrous bands that you are seeing. Okay, and the staining that you use to visualize the fibrous band, it is known as the trichome staining. Very important. The trichome staining is done to visualize the fibrotic bands. This is the fibrosis, this is the collagen deposition. Trichome staining is used for the collagen detection, right? And because of fibrosis is nothing but the collagen, the deposition of the collagen. As you can see here, this is a trichome staining, right? For detection of collagen. So these kind of regenerating nodules will be formed, okay, and the nodules will be surrounded by the fibrous bands, right? Even if you look at the liver grossly, you will see the nodular structure of the liver from the regular smooth one to the nodular one. Okay, so this is the alcoholic cirrhosis. Okay, and again you will get a portal hypertension, you will get the end stage liver disease in that. Okay, after that the liver can progress to the hepatocellular carcinoma, right? And because the liver is completely become dysfunctional, the only thing you can do is the liver transplant after this stage. Is that okay up to here?
Yeah.
Now for the liver disease, okay, the PT will rise first, and after 21 days the albumin will be fall, right? But in the acute stages only PT changes will be there, right? And for the alcoholic, you guys already know that AST will be always higher than the ALT, and these ALT AST must be less than 500. Okay, and yeah, that would be it. Then comes the non-alcoholic fatty liver disease. In these diseases, you are still having the fat in the liver, but it is not associated with the liver. Okay, it includes some metabolic syndromes, right, in which you get the insulin resistance, and because of the insulin resistance, you will be like in case of obesity. Okay, you will be having a fatty infiltration of the hepatocytes. The ballooning of the cell will occur. As you can see, all the cells will be swelled up by the accumulation of these fats, and these are known as the ballooning cells. And eventually, the necrosis of the cells will happen. Cirrhosis can happen, and that can lead to the hepatocellular carcinoma. Okay, it is all independent of the alcohol use. Okay, so this non-alcoholic fatty liver disease, it only seen in the obese people with the metabolic syndrome. And does anyone remember the features of metabolic syndrome?
Hyperlipidemia, insulin resistance, and diabetes, hypertension.
Hypertension,
Yes. And the central obesity, right?
central obesity.
So in these patients, you can have the accumulation of the fat within the hepatocytes, right? And as a result, the patient can have a non-alcoholic fatty liver disease. The damage will continue, and the necrosis will happen, the cirrhosis will happen, and that can lead to the hepatocellular carcinoma. In that case, you will be having a high ALT count and the AST count because it is not a alcoholic type of injury. Is that okay?
I have a question.
Yes.
In alcoholic liver disease, which zone of the liver is affected? Like zone 3? Is it zone 3 or zone 1?
It is not specifically written with zone affected, but the complete damage would be there, of course. And you know that they see every toxin which comes into the liver, it will be detoxified in the zone 3, right? So so at a very initial stage, the zone 3 will be damaged first, then the zone 2, then the zone 1. But all three zones will be affected, okay?
Okay.
It is not limited to a specific zone.
Can you explain the third picture in the alcoholic liver disease?
This one,
Yeah.
this is alcoholic cirrhosis. Whenever you get the cirrhosis, you will get the fibrous bands in the liver, right? Because of a destruction of complete architecture, still some stem cells are remaining in the liver, right? These stem cells will regenerate and they will form some nodules known as the regenerating nodules. Okay, and these regenerating nodules, they will be surrounded by the fibrous bands, as you can see. And you already know that fibrosis is nothing but a deposition of collagen, right?
Yeah.
Okay, and the collagen will be detected by the trichome staining. Okay, whenever you do the trichome staining, you can easily detect the presence of collagen. So as you can see, this bluish structure, this is all the collagen, right, which is forming the fibrotic bands. And you can easily detect it with the help of trichome staining, right?
Right. Okay. Thank you.
And step one can ask you why this fibrosis is happening, what cells are responsible for that. These are the stellate cells or the ito cells. Okay, remember that. Now, the hepatic encephalopathy, we have discussed that many times. Why this is occurring? Because of high ammonia level. And because of the high ammonia level, you will be having a cerebral edema, you will be having astraxis, you will be having a slurring of the speech, you will be having a loss of TCA cycle, cell death would be there, neuropsychiatric dysfunctions would be there, you will be having a excitotoxicity because of loss of GABA and glycine, right? So these are all the symptoms for the hepatic encephalopathy, right? Triggers will be the increase in the ammonia production and decrease in the ammonia clearance. Of course, that's how you can get a high ammonia levels. Okay, and the increased ammonia production and absorption includes the GI bleeding. Okay, very important. It is very high time, most of the times along with the portal hypertension, you can also have the GI bleeding. Okay, and that GI bleeding can further promote the ammonia absorption, right? And that can lead to the hyperammonia. Very important. Step one will ask you this thing. Okay, why you are having a hyperammonia, how you can have a high absorption of the ammonia? It is because of the GI bleeding, right? Constipation can do that. Infection, because there are bacteria, and these bacteria will release the ammonia, especially if you get the this spontaneous bacterial peritonitis, right? You can have a high ammonia level because of these bacteria, right? Second thing would be to decrease the removal of this ammonia. Okay, if you do the TIPS, like, okay, in case of TIPS, you will be bypassing the liver so that the clearance of the ammonia can never happen. Okay, using the diuretics will decrease the clearance of ammonia, right? And yeah, in case of in case of renal failure also, you can have a decreased clearance of ammonia. So in all these conditions, you're having a decreased removal of ammonia. So triggers, two types. One is increased production, second is a decrease in the clearance, right? And yeah, that would be all about it. So what is the treatment? You cannot do the TIPS in case of hepatic encephalopathy because it will further uh, uh, cause more complications, right? So what you can do, you can give the patient lactulose. We have discussed that already. Okay, it is works like the lactose. Okay, the bacteria which are present in the GIT, they will feed on this lactulose. They will increase the they will decrease the pH of the GIT, right? And when the pH is decreased, it will bind to the ammonia and converting into the ammonium ion so that it could be excreted in the feces. Second thing you can do is to give a patient rifaximin. Okay, rifaximin inhibit the growth of the bacteria which are releasing the NS3, and as a result, what you can have is a low level of NS3. Is that okay? Up to here?
Yes.
So please remember, whenever we have an uncomplicated type of portal hypertension, TIPS can be performed. But whenever you have a portal hypertension along with the hepatic encephalopathy, you will not do the TIPS. You will give the patient drugs like lactulose, rifaximin for the hepatic encephalopathy, and for the portal hypertension, you can give the patient somatostatin analogs or other drugs like, remember,
Beta blockers.
beta blockers could be given, could not. No, not beta blockers are especially for the this esophageal varices. They are not much useful for the expansive vasodilation thing. Okay, so what are the drugs? I'm also forgetting this. Yeah, the furosemide and the spironolactone, right? The diuretics. Okay, these things you can give to decrease the edema, to decrease the ascites and the portal hypertension. Is that okay up to here?
I have one question.
Yes.
Why does the diuretic act as a trigger?
Volume, renal dysfunction. Because if you use a diuretics, then what's gonna happen? Hypovolemia, right?
Yes.
If the hypovolemia occurs, then the renal blood flow will be decreased.
Yeah.
If the renal blood flow is decreased, then what's gonna happen to the ammonia levels and the creatinine levels? They will rise.
Yes.
That's how.
Okay. Thank
You can still give the diuretics in case of this hyperammonia, but only in the controlled amount, right? To just decrease the edema part only. Okay.
Yeah. Okay. Thank you.
So that's all about the hepatic encephalopathy. Okay. And yeah, that's all. Any doubts so far? You can ask anyone.
No, thank you.
So we are moving forward now. If we are given spironolactone without the tolvaptan, then it will cause the worsening of hyponatremia further. Okay. Yes. Is that a doubt or is that a statement? Oh, okay. Yeah. Cool. Okay, then you know to know about the autoimmune hepatitis. A very important thing. It is an inflammation of the liver because of the autoimmune system, right? Because of the autoimmunity. So what's gonna happen? The first thing you need to know about that all symptoms of the hepatitis will be present, like the right upper quadrant pain, the jaundice, okay, and the nausea, vomiting, abdominal discomfort, weight loss, fever, okay. All of things would be there for the liver injury, right? And this is a classical presentation for any kind of liver injury, right upper quadrant pain, fatigue, weight loss, nausea, vomiting, okay, and abdominal pain, jaundice, right? For the labs, you will have the high ALT count, high AST count, alkaline phosphatase levels could be normal, could be elevated sometimes, but most of the times normal, right? You will have the high bilirubin levels, and the most important thing is you will have the high levels of anti-smooth muscle antibodies. Please note that whenever you encounter a patient having a anti-smooth muscle antibody positive, that means the patient is having a autoimmune hepatitis. Okay, it is because of the T regulatory cell dysfunction that will lose the self-tolerance, and as a result, they will start acting against the hepatic antigens. They will start destroying them. So what you will see on the microscopy or on the biopsy of the patient, when you take the biopsy of the liver, you can see the lymphocytes and the plasma cell infiltration. Very important. Lymphocytes and the plasma cell infiltration. The plasma cell infiltration is showing that it is a chronic injury, not an acute injury, right? Very important. You will have the lymphocytes and the plasma cell infiltrations. And it is mostly seen with the women's, okay, with other autoimmune conditions. So it could be a woman having, having a family history of other autoimmune conditions, or she itself having some other autoimmune conditions. And whenever you encounter a patient with one autoimmune condition, she or he can also develop another autoimmune conditions also, right? So mostly seen in the women with other autoimmune conditions. Is that okay?
Yes.
Then you need to know about the patterns of the liver injury. Two types of liver injuries are there. One is the hepatocellular, which means a direct damage to the liver. And second is the cholestatic, which means a direct damage to the bile tract. Okay, whenever a direct damage to the liver occur, that can lead to a high level of ALT, AST, and these levels are more than the alkaline phosphate level, right? Plus, you will get a high level of bilirubin. In case of a cholestatic pattern of liver injury, you will have the alkaline phosphate levels more than the ALT, AST. Okay, so whenever you encounter a patient having a ALP level more than ALT, AST, that means it's a cholestatic pattern. That means a bile tract, the bile duct or a bile tract is being damaged, not the liver directly. Plus, you can also have a high GGT count, okay, and you can have a high bilirubin levels. Is that okay? The two type of liver injuries, hepatocellular and the cholestatic. So whenever you have the cystitis or the cholangitis or the cholangiocarcinoma, right? In all of these scenarios, you will have this type of injury. You will have a high alkaline phosphate levels than the ALT and AST. In case of any hepatitis or cirrhosis, you will have the high ALT AST count than the ALP. Okay. Are we good?
Yes.
Yes.
Okay, so just by looking at the levels of these enzymes by the labs, you can tell easily whether a patient is having a damage to the bile duct or a damage to the liver. Okay. Then let's discuss about the hepatocellular carcinomas. Okay. And you already know the risk factors for the hepatocellular carcinomas, any cirrhosis, any hepatitis, right? They can cause a hepatocellular carcinoma, right? And the most important one among this is the food, which is the aflatoxins, right? Aflatoxins from the aspergillus, okay, which generally causes the infection in moldy grains, right? In the grains, right? And so, yeah, these aflatoxins are a very important cause for the hepatocellular carcinomas, right? Hepatitis B virus, hepatitis C virus, alcoholic hepatitis, non-alcoholic fatty liver disease, autoimmune hepatitis, hemochromatosis, Wilson's disease, alpha-1 antitrypsin. So any disease which can cause a hepatitis, they can cause the hepatocellular carcinoma. Is that okay?
Yeah.
And because of the cancer, you are having a hypercoagulable state, and that can cause the Budd-Chiari syndrome also, right? And because the metastasis mostly happen because of the blood circulation, right? Because of the portal vein, they can block the portal vein also. That can again lead to the Budd-Chiari syndrome in the hepatocellular carcinoma. Findings again includes the patterns of liver injury, which means the right upper quadrant pain could be there, hepatomegaly could be there, jaundice could be there. Okay, just like any other cancer, weight loss, fatigue, anorexia would be there. Okay, and you will also get the polycythemia, you will get the ascites, right? And yeah, this tumor will spread the hematogenously. Please note that it is, although it is a carcinoma, and most of the carcinomas spread through the lymph nodes, this carcinoma is spread through the blood vessels. It is also very important. So how will you diagnose the condition? First thing you can do is a CT or MRI of the patient. Okay, on the CT and MRI, you will see a large mass. Okay. Second thing, you can do the biopsy. On the biopsy, you can check for the NC ratio, for the mitotic figures, for the nucleolus. Okay. For the labs, you can do the alpha fetoprotein levels. You can check the alpha fetoprotein levels. If it is elevated, then it will confirm the diagnosis of the hepatocellular carcinoma, right? And you also need to know that the secondary cancers are kind of more common than the primary cancers. Secondary cancers by means metastatic cancers to the liver are more common than the primary cancers. In the metastatic cancers, you will have a multiple foci of the cancer. Okay, if I draw the liver here, like see, this is a CT of the patient for say. Okay, this is a liver. In case of a metastatic injury, okay, in case of metastatic tumor, they will show multiple nodules of approximate size. You know, they have kind of the same size. Multiple nodules will be seen. Okay, and whenever you see the multiple nodules of kind of same size or slight increase or decrease, that means it is a metastatic type injury. Okay. In case of a primary tumor of the liver, if this is my CT of the liver, you will first have a very large solitary mass like that. Okay. Multiple nodules could be there, but other nodules are very much smaller than this primary nodule. Right? Multiple nodules could be there, but all of these nodules are very much smaller than this primary nodule. So whenever you get this type of CT, a very large solitary lesion, nodule, and then some other smaller multiple nodules, that means it is a primary tumor of the liver. If you get multiple nodules of same size approximately, then it means it is a secondary tumor of the liver. Is that okay?
Yeah.
As you can see on this figure also in the first aid. So this is a one solitary nodule, and then some other multiple small nodules are also there. So multiple nodules are in both the primary and the secondary tumor, right? But in case of a secondary, they are kind of same size. In case of primary, one is a very large size and other a very smaller size. So that's about the hepatocellular carcinoma. Just know the risk factors, know how to diagnose the conditions, what symptoms will be present, okay, what you will see in the biopsy, what labs would be there, right? Then comes the other tumors. The first one is the angiosarcoma. You guys already know the risk factors for the angiosarcoma. We have discussed that previously, right? The arsenic and the vinyl chloride or the PVC, right? They are the cause of this angiosarcoma, right? And these tumors are of endothelial origin. That's why the name angio means blood vessels, right? Please note the tumor marker, which is the PCAM1 molecules. Does anyone remember the PCAM1?
Endothelial that helps in transmigration of lymphocytes.
Exactly. The PCAM1 of the neutrophils will interact with the PCAM1 of the endothelial cells, and as a result, the neutrophils will be transmigrated. Okay, so whenever you have a blood vessels tumor, like the angiosarcoma, it would be PCAM1 bridge. Okay, and these are highly malignant tumor. Okay, and you will have the malignant transformation at a very early stage. Okay, the metastasis will happen at a very early stage in these tumors, right? Second thing is the cavernous hemangioma, which is the most common benign tumor of the liver. Okay, it is like a venous malformation, right? And the biopsy of the tumor is contraindicated because whenever you do the biopsy, you are doing the biopsy of a blood vessel. Okay, it will cause the bleeding, right? So you won't do the biopsy of these lesions, okay, because of tendency to the leak. And what you will see on the biopsy, if you somehow get the biopsy, what you will see is that dilated blood vessels with lot of blood in them, like that. Okay, dilated blood vessels with lots of blood in between in them, and between two blood vessels, there's a very minimal stroma. As you can see, there's a very minimal stroma in between the two blood vessels. This is one blood vessel. This is second blood vessel. As you can see, a very minimal stroma is there. Okay, smooth muscles are absent. Okay, elastic fibers are absent. Only the endothelial cells are present. That's why the tumor of yeah, and that is about the cavernous meningioma. The third type is the hepatic adenoma. Earlier we have studied about the carcinoma. This is the hepatic adenoma. It is only seen in the females taking the OCPs. Very important. It is only seen in the patient taking the OCPs, and as soon as the patient stop taking OCPs, the tumor will be resolved. Okay, the tumor will be regressed with the discontinuation of the OCP. It will be shown as the tan-colored nodule in the group. Very important. If the step 1 describe you a tumor in the female taking the OCP, okay, a tan-colored tumor in the liver, that means they're talking about the hepatic adenoma. Okay, and what you will see is the columnar cells. Okay, because it is adenoma type. You will see the glands. Okay, and wait. Then the metastasis we have discussed. Metastasis are secondary tumors, okay, and they are more common than the primary ones. The most common site of metastasis is your colon, okay, and the metastasis generally happen because of the portal circulation from the GIT. Okay, every tumor will reach to the liver with the help of portal circulation. From the liver, it will enter the hepatic vein and then to the systemic circulations. Is that okay? So these are about the GI malignancies. From the breast and from the lung cancer, the hepatic artery can cause a metastasis to the liver, right? Overall, metastasis is kind of a very rarely solitary. Okay, multiple tumors would be seen. Okay, unlike the case of your primary tumors, in case of primary tumor, a solitary lesion would be there. In case of metastasis, multiple lesions would be there. Is that okay?
Yeah.
So that's about the cancers of the liver. Any doubts so far?
No, thank you.
Okay, now the Budd-Chiari syndrome, which is the thrombosis of the hepatic vein. Okay, and what you will have first, because of the congestion, because of the obstruction in the venous drainage, you will have the congestion in the central vein, because you guys know that the hepatic vein is made up of central veins. So the pressure in the central veins will be raised, and that can cause the necrosis and the ischemia, because you guys know that ischemia can happen because of decrease in the arterial supply and because of a decrease in the venous drainage. Is that okay?
Yeah.
So because of a decrease in the venous drainage, you can have a ischemia, right? And yeah, so first thing you will have is the central necrosis, because the zone 3 will be near the central vein. So this zone 3 will be most commonly affected. You will have the necrosis in the central zone. Is that okay?
Yes.
You will have the hepatic congestion, you will have the hepatomegaly, you will have the ascites, you will have the varices, you have the abdominal pain and the liver failure. The one who was asking me about the question about this ascites thing, see, the Budd-Chiari syndrome can also have the ascites.
Yeah, but
Okay.
I have sent a question in the group. You can check out yourself and kindly clear this doubt of mine.
Okay, sure. I will check that question. Don't worry about that. Okay.
Thank you.
And
Thank you, sir.
you will have the absence of jugular vein distension. Can anyone tell me what this means?
We can eliminate cardiac cause of.
Exactly. In case of the the same symptoms can also happen in case of heart failure. In case of heart failure, you will be having a volume overload in the veins, right? You will have the hepatic congestion, you will have this central lobular necrosis, everything would be there, right? But in liver, in heart failure, you will also get the jugular vein distension. But in case of a Budd-Chiari syndrome, you won't get the jugular vein distension, because your heart is absolutely normal, right? And because of that of this Budd-Chiari syndrome, yeah, that would be everything, right? You can also have the liver failure, because the normal architecture of the liver is being destroyed because of the ischemia and necrosis, right? So hepatomegaly, ascites, varices, abdominal pain, and liver dysfunction would be there in case of Budd-Chiari syndrome. And please remember, it would be a central lobular congestion and necrosis. Okay, the periphery parts are absolutely normal. In the central, you will see the complete pink structure, which means the necrosis. Is that okay?
Yeah.
Now you need to know about the causes of the Budd-Chiari syndrome. It includes the hypercoagulable state, which can generally happen with any cancer, okay, with stasis, okay, and with this clotting factor abnormalities, right? Second thing is the polycythemia vera. Because of the polycythemia vera, you will be having very high viscosity. So the blood can clot very easily because of this highly viscous blood, right? Third thing is the postpartum state. Because of the postpartum, you will be having a very high clotting factors in the blood, right? That can cause the Budd-Chiari syndrome also. In the hepatocellular carcinoma, because these cells will be metastasized by the portal vein, by the hepatic vein. They can block the hepatic vein. They can cause the Budd-Chiari syndrome. Okay, you can also have the Budd-Chiari syndrome in the paroxysmal nocturnal hemoglobinuria. Okay, and what you will see is the nutmeg liver, which is a mottled appearance. A very swelling would be there in the liver, the hepatomegaly, right? Because of the hepatic congestion. Okay, so any doubt in the Budd-Chiari syndrome so far?
I have one question.
Yes.
Why does postpartum state increase the chance of Budd-Chiari?
See, because you know that in case of pregnancy, you will be having a very high clotting factors, right?
Okay.
And as soon as the pregnancy ends, you don't need the clotting factors much, because initially you need the clotting factors for the bleeding complications.
Yeah.
But now this condition is gone, but you still have the high clotting factors, right? That can cause the more the platelet accumulations and more the thrombosis, right? And that can cause the this hypercoagulable state, right?
Yeah, got it. Thank you.
Now in the case of alpha-1 antitrypsin deficiency, okay,
I have a
this and yeah.
Do we get heart failure cells in liver congestion secondary to Budd-Chiari?
Yeah, of course you can get, but these are not the heart failure cells. These are just the macrophages with lots of RBCs in them. Heart failure cells are specifically for the heart failure only, right? And these cells are nothing but the macrophages. Even in the heart failure cells, these heart failure cells are nothing but the macrophages with lots of iron, right? With lots of heme.
Yeah.
Similar thing you can also get in case of this liver also. But you won't call them the heart failure cells, okay?
Okay. Thank you.
Okay, then comes the alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is basically a protein. It is a glycoprotein first thing, okay, which means it would be the pass positive if you stain the protein, right? It is synthesized in the liver, okay, and it will reach to your lungs. Okay, in the lungs, the function of this alpha-1 antitrypsin is to inhibit the elastasis. Okay, is to inhibit the elastasis so that it could prevent the the destruction of the elastin in the lungs, because you guys know that lungs is a highly elastic tissue. It requires elastin, right? If the elastin is degraded, what's gonna happen? Your lungs become very dilated, right? So the function of this alpha-1 antitrypsin, which is a serine protease inhibitor, you also call that a serine protease inhibitor. Its function is to inhibit the elastasis. Now, in case of alpha-1 antitrypsin deficiency, it is a codominant trait, okay, which means even if you get a one mutation, okay, both the normal gene as well as the abnormal gene, they both will express themselves. Okay, that's why it is a codominant trait. Okay, now because of the mutation, you will get a misfolded gene. Okay, and this misfolded gene and the protein will be aggregate within the hepatocellular endoplasmic reticulum, right? And as a result, it will cause the cirrhosis. It will cause a damage to the cells, the hepatocytes, because they will start building up within the cells. And when it start building up within the cells, that can cause the damage to the hepatocyte. Now, can anyone tell me, if I'm having a building up of the misfolded protein, why my proteasome is not acting on it? I'm having a building up of a misfolded protein. Why my proteasome is not acting on it? Why the building up of this protein is occurring?
Because the protein is still inside the ER and not in the cytoplasm.
Exactly. Because the protein is still in the endoplasmic reticulum, not in the cytoplasm, the proteasome cannot act on it. And that is the reason why in case of alpha-1 antitrypsin deficiency, I'm having the cirrhosis. Why I'm having the building up of this misfolded protein. And because of the building up, it will damage the hepatocyte and it will cause the cirrhosis. And when you do the liver biopsy, what you will see is the pass positive globules, because you guys know that this protein is a pass positive protein. When you stain it, you can see these kind of globules. These are the endoplasmic reticulum filled with the alpha-1 antitrypsin. Is that okay up to here?
Yeah.
Now, first thing you get is a liver injury. Now, because this alpha-1 antitrypsin cannot go to the lung now, okay, you have a deficiency of this enzyme in the lungs also. As a result, the elastasis will become super activated. And because of their activation, they will start degrading the elastin. And you guys know that this elastin is responsible for the elasticity of the lungs. And what does the elasticity means? Anyone? We have discussed that in the CVS about elasticity and the compliance.
Ability to elastic recoil.
Or you can say the ability to regain its original shape, right? Whenever you stretch it. Yes. So in case of lungs, whenever you inflate them, right, the lungs have to come back to their normal position, to their normal shape, right? And they can do that with the help of this elastin. If this elastin is lost, then then the compliance of the lung will become too much, and that will cause the dilation of the air spaces, and that can lead to the panacinar emphysema. Okay, so in lungs you will get the COPD, you will get the panacinar emphysema. In the liver you will get the cirrhosis. So whenever you encounter a patient with a chronic history of coughing, okay, it could be a wet cough, which means a productive cough, okay, with a shortness of breath, okay, and with other things, with a high CO2 levels and any other thing, just like the emphysema, along with the high ALT AST count and the hepatic cirrhosis, that means the patient is having a alpha-1 antitrypsin deficiency. And please note that they are most commonly the teen patients or a very young age patient with a minimal history of smoking. Okay, you generally require at least, I think, 40 years of smoking history to get a emphysema because of smoking, right? 30 years, I think, smoking is required to get the emphysema. Okay, if you get the patient having a history of smoking for like 5 or 7 years only, and now he's getting the emphysema, that means it is because of the alpha-1 antitrypsin deficiency. Is that okay?
Yes, I have one question.
Yes.
Since alpha-1 antitrypsin deficiency can also cause cirrhosis, can this cirrhosis also lead to hepatocellular cancer?
Yeah, of course.
Okay, okay. Thank you.
Any kind of cirrhosis can lead to the HCC. Okay.
Okay, thank you.
Okay, so what you will get is the emphysema, which means the hyperlucency on the chest X-ray will be seen, the dyspnea will be seen, flat diaphragm would be seen, shortness of breath would be seen, chronic cough would be seen in the patient, right? Along with that, the patient will also have the jaundice, the the hepatomegaly would be there, right? And because of cirrhosis, the portal hypertension would be there, and other abnormalities could also be there in the patient. And this patient must be a young patient, very importantly, right? This patient must be a young patient, not the old age. Okay, so any more doubt about the alpha-1 antitrypsin? That's all about it.
No, thank you.
Okay, now you need,
So
yeah.
we get past pain positive in alpha-1 antitrypsin deficiency.
Yes.
So how would this can lead to cirrhosis? So how would we differentiate between the cirrhosis because of glycogen storage diseases and alpha-1 antitrypsin deficiency?
Well, you will get the lung symptoms also, right?
Okay.
It will only present in the alpha-1 antitrypsin. You won't get the lung symptoms in the glycogen storage diseases, right?
Yeah.
History is important, of course. History, a teen patient would be there with some shortness of breath, and all this chest X-ray would be abnormal, and then he's getting this the cirrhosis. That means it is alpha-1 antitrypsin deficiency. If he's getting just the heart involvement, might be there, dilated the cardiomyopathy, right? It could be the muscle pain, right? It could be just the liver damage only. That means it could be the glycogen storage diseases. So it depends upon the symptoms, of course.
Okay. Okay. Thank you.
Yes. And important thing also, you will get the globules in this in the histology. See, the globules are there, right? But in case of the glycogen storage disease, we'll get a diffuse pink, a diffuse staining would be there because they are present in the cytoplasm of the hepatocytes, right?
Yeah. Okay.
So globules are only present in case of alpha-1 antitrypsin deficiency. Okay, now let's talk about the focal nodular hyperplasia. See, this focal, just give me a second. So this focal nodular hyperplasia is, is not a cancer. It's not anything. It's just because you're having a AV malformation in the liver, a kind of AV malformation in the liver, and as a result, okay, what's gonna happen? Just give me a second. So because of this vascular abnormality in the liver, you're gonna have a localized hyperperfusion, right? You will be having too much oxygen, you will be having too much nutrients, you will be having too much growth factors. And these things, this localized hyperperfusion will promote the hyperplasia of a particular area in the liver. Are you getting my point? The first thing will happen is the vascular abnormalities. And because of the vascular abnormalities, the liver will started having the hyperperfusion. And because of this hyperperfusion, the proliferation of the liver parenchyma will occur, right?
Yes.
And that can lead to the focal nodular hyperplasia. It will be a very specified area in the liver, okay? And this hyperplasia will be occurring in that specific area only. This condition is totally asymptomatic, totally benign condition, no cancer. Even if you find the condition, there is no need for any operation or anything. You will lead the condition just like that. Most commonly, this is an incidental finding. The patient can become for some other regions, right? And you do the CT of the patient, and you incidentally find this lesion in the liver, okay, the FNH, right? Sometimes it could be autopsy finding also. After the patient dies, when you do the autopsy, you can find this kind of focal nodular hyperplasia, right? Now, what are the features of this focal nodular hyperplasia, what you will see on the CT examination, this is important. See, you will have a localized tumor first, not a tumor, you will have a localized growth. Okay, it is a very solitary lesion and a very well circumscribed lesion. Okay, a very well bordered lesion would be there. It is very smooth lesion. Okay, this lesion also contains some fibrous septas, as you can see. Fibrous septas are there, and these fibrous septas will be dividing this complete lesion into some multiple nodules. Okay, on the center of the nodule of this lesion, there would be a stellate scar. Okay, this would be a fibrotic area in the very center. Okay, and on the periphery there will be a kind of very solitary lesions, as you can see. So as a solitary lesions in the center, it would be a stellate scar. Okay, and from this scar there will be the fibrous septa originating, which were dividing this complete lesion into some multiple nodules. This is what you see in the CT. If I open up a CT for you for the focal nodular hyperplasia, just give me a second. That we will better understand that. Yeah, see, as you can see in the this is a complete solitary lesion. A well circumscribed solitary lesion would be there, right? In the center, there would be a stellate scar, as you can see, a fibrotic area. Okay, and originating from these fibrotic areas are the fibrous septas, as you can see. These are the fibrous septas, and these fibrous septas will be dividing this whole lesion into some multiple nodules. Okay, this is what you see on the CT scan of the patient. Is that okay?
Yeah.
So that's about the focal nodular hyperplasia. They will likely to ask you the cause of it. Okay, the cause is nothing but just the hyperperfusion. Because of the vascular abnormalities, the area of the liver will get the hyperperfusion, and because of that, the cells within that area, they will be start proliferating and they will form this focal nodular hyperplasia. They will get hyperplasia, right? It is only the incidental finding. Accidentally will discover it while doing the regular CT examination, or while doing the this autopsy of the patient. Okay, so any doubt about this focal nodular hyperplasia?
No.
Okay, so we will wind up here for today. Okay.
Okay.
Thank you, everyone.
Thank you so much.
Thank you.
Thank you.
Thank you so much.